here?
I think Devendra's recording also.
Oh, right, okay.
That's on my computer. Lisa can start.
Yeah.
On her computer.
Are you okay, Diane? You're on mute.
Sorry.
There we
Hi.
are.
Yeah, I'm here.
Good stuff. Excellent.
Hi, good to see you, Dan.
Hi, Devendra.
So it must be very late. Is it 11 o'clock there or?
Oh, it's not too bad. It's 9:30.
That's 9 at night, isn't it?
Too bad.
So you are in the New South Wales.
Yeah. Where I'm in Sydney.
Yeah, Sydney. So the Sydney and the difference between Sydney and Victoria is 1 hour.
No, Victoria is on the same
Same.
time as Sydney. But there's about 3 hours between the East Coast and the West Coast.
So Adelaide must be 1 hour away from.
Yeah, something like that. Yeah.
And then of course the East West Coast Perth will be 3 hours.
Yeah, something like that. Yeah, exactly. I'm glad you're recording the meeting because there's lots of talks I'd like to listen to, but they might be on at 3 a.m.
Yeah, we will post it, the recording, and then we'll post on the website.
Some people have asked Devendra when the videos will be available online. Do you know sort of timescales with Robert and his editing and his schedule?
I should give 1 week actually.
1 week, okay, fine.
We could sooner, but we've not even started. I mean, there will be a lot of unnecessary information, so we have to really delete those sections.
Yeah.
And then put them together. I would prefer actually each talk separate, so that people will have a choice of which talk to listen. So we got 2 from your center, Diana, yourself and Elena.
Yeah, no, that's great.
That's great. Thank you very much for your support.
Well, I mean, I suppose the thing is with the Zoom format is that you can get a lot of people from all over the world, and it's a much cheaper way of.
Oh yeah, I mean, this is I call it blessing in disguise. You know, I mean, I'm sitting here without moving, and myself and Nick, in the last conference you came to York, you remember, I think it was really a big job to arrange transport and accommodation,
hotels,
and everything. It was so much.
That's right.
And then the budget was quite big, and now budget is small, and then people can come join from sitting from their office or bedroom, whatever, you know. And today we have got speakers, 3 speakers from USA, 1 from Canada, and 2 from Australia. And only one from England, only from UK, only 1 speaker. So today is International Day.
And that would have cost us a fortune to get you all here.
Oh, impossible. I mean, there's no funding, as you know.
No. There's no Eleanor who's chairing this session is not online yet. I've sent her an email.
Or Caroline.
Yeah, no Caroline
isn't
either. I mean,
either.
she's after Diane.
What time is it now?
It's 25 past.
We sent a message to Eleanor.
I have sent in a message to Eleanor. I'm just digging out Caroline's email address. Don't know if I have it actually.
Dr. Eleanor's been on all week, hasn't she? So she's quite familiar with it.
Yeah. Devendra, do you have Caroline's email address? I'm just looking at all the information that I've sent out to everybody. just
I'm
thinking.
I've just send the SMS to her.
Oh, perfect. Devendra, yeah, you might have to chair this one if Eleanor doesn't come on.
Can I just check my slides are all okay, Nick?
100%, yeah, absolutely.
Okay, so I'll just share my screen for a minute
Yeah.
and I will, a minute.
Go into presentation mode. That's it.
Okay,
Yep.
that all looks good.
All good?
All right,
Perfect.
okay.
Perfect.
How many have joined so far? No, not very many people.
No, everyone must be having a lie-in or something. We've got 12 in the waiting room at the moment.
I think they can all be admitted now.
Yeah, admit everybody. Okay. Right. I'm gonna slope off into the background.
Myself too, good luck.
Good luck, everybody.
Okay. Erin has joined. Yeah, she's joining now. Hi, Elena.
Hi, Devendra. How are you?
We're getting a bit anxious, so I sent the SMS.
Yeah, I know, I got it. Don't worry, I was on time.
Yes, somebody has got a
Yeah, someone needs to mute.
double extra device, I think.
I suggest we give it a couple of minutes just for people to join.
So, looks like we need to give more time today. People are slow to join.
So we'll just wait a couple more minutes just for people to join, and then we'll start in a couple of minutes. Devendra, I think it's such glorious weather over here, which has been unusual for the UK this summer. So we've got some competition with the weather outside, I think.
Apparently, I just got a message from Caroline that didn't have the link, so I've just sent the link. So yeah, I mean, it looks all right, you know.
Fantastic.
Yeah, she's here now. Okay, I think we are all right now for this.
Brilliant. So welcome everyone to this session on therapeutic cardiovascular genomics. So we have two fantastic speakers lined up today who are joining us from across the world, both from Australia and from the United States. So may I first introduce to you Professor Diane Fatkin, who will take us through the new era of precision medicine and dilated cardiomyopathy. So Professor Fatkin she's a molecular cardiologist with research interests in inherited heart diseases, particularly familial forms of dilated cardiomyopathy and atrial fibrillation. So she originally trained in medicine and clinical cardiology, and following on from her MD studies at St. Vincent's Hospital, Professor Fatkin undertook a postdoctoral fellowship at Harvard Medical School in the US. She then returned to Australia to establish her own research group at the Victor Chang Cardiac Research Institute, and her current appointments include both being an honorary medical officer in the cardiac department at St. Vincent's, but also she's a professor in the faculties of medicine and science in the University of New South Wales. So she has spearheaded a number of research projects and breakthroughs and has identified the genetic cause of a heart defect by studying 42 members in just the same family. And this discovery actually has enabled her to recommend a specific treatment, so a specific drug that actually has altered the defect caused by the faulty gene, rather than just relying on standard heart failure medication. And this has led to an unprecedented complete normalization of cardiac function, personalizing medicine in this area. So it's with great pleasure that I hand you over to Professor Fatkin, who will take us through the role of personalized medicine and dilated cardiomyopathy. So Professor Fatkin, if you'd like to share your screen. Thank you very much.
Thanks very much, Caroline, and thanks also to Devendra for the invitation. It's fantastic to be able to join you at the conference today. So I'd like to start with some historical perspectives on cardiomyopathy genetics. And so it all really began with clinical reports of familial clustering of disease and linkage studies in kindreds. But the first disease gene for any inherited cardiomyopathy was only described in 1990. And this is where the field of molecular genetics of cardiomyopathies was really born. And this was the MYH7 gene mutation in hypertrophic cardiomyopathy that was discovered by John Christine Seidman. And this spurred several decades of candidate gene screening in research cohorts This led to the discovery of large numbers of disease genes for the various cardiomyopathies. The next major advance was the development of next generation sequencing technologies, which meant that multiple genes could be evaluated in parallel. And this led to multi-gene panels, exomes and genomes, and really formed the basis of clinical genetic testing. But the cost of genetic testing and who pays has been a limiting factor in many places, certainly in Australia. It was very pleasing recently that we had a successful application to get Medicare reimbursement for doing cardiomyopathy genetic testing. So in 2021, genetic testing is now widely available and affordable. But what is its role in clinical practice? So of course, the main reason why genetic testing has been performed to date has been to identify the cause of disease in a proband and do predictive testing in family members. And this allows individuals at risk of developing disease to be identified and follow-up strategies and medical surveillance to be undertaken. But what I'd like to propose today is that genetic information represents much more than that at this point in time. And so I'd like to focus on dilated cardiomyopathy to make some of these points. So when we're thinking about all those hundreds of genes that I mentioned previously, there are some patterns. So with hypertrophic cardiomyopathy, most of the disease genes encode components of the sarcomere. In ARVC, they're mainly components of the desmosome. But in dilated cardiomyopathy, we're looking at genes that are located in diverse parts of the cardiomyocyte, not only in the sarcomere, but also in the cytoskeleton and the nucleus and various other locations. So one of the first genes that was associated with dilated cardiomyopathy was the LMNA gene. And this encodes two proteins, lamin A and C. And these are important components of the nuclear lamina, which is this layer here just underneath the nuclear envelope in cardiomyocyte cells. And the nuclear lamina is a very important determinant of nuclear structure and function. Now, LMNA gene mutations are the second most common cause of dilated cardiomyopathy, but they're arguably the most important. And this is due to the significant complications, including atrioventricular block, ventricular arrhythmias, heart failure, stroke, and sudden death. And of course, what is a distinguishing feature of lamin mutations is the characteristic phenotype where patients often present with conduction defects and atrial fibrillation, and this may occur decades before they get dilated cardiomyopathy. So this is an important study by Saurabh Kumar and colleagues when he was working with Neil Lakdawala and Caroline in Boston. And so they looked at 122 lamin mutation carriers and followed them for a median of 7 years. And you can see here when the events are plotted against the age of onset, that this characteristic prodrome of atrioventricular block and atrial arrhythmias occurs years before heart failure and ventricular arrhythmias and complications. But this is really a very important part of the story here, where we look at the number of patients who are affected at the end of the follow-up period. And you can see here that almost 80% of the patients had developed atrioventricular block and atrial arrhythmias, as well as dilated cardiomyopathy, with 50% having ventricular arrhythmias and a significant number having sudden death and end-stage heart failure. So these data are really important and underscore the fact that LMNA cardiomyopathy has a poor prognosis. So I'd just like to spend a moment looking at a family with a LMNA missense mutation. So the index case here was diagnosed with dilated cardiomyopathy at the age of 24. And he had a really nasty family history where his dad here died at the age of 35, 6 months after his DCM diagnosis. And his brother died at the age of 22, only 2 weeks after his DCM diagnosis. I'd like to focus here on this individual who underwent family screening, and when we first saw him, he had a completely normal echo. He then went on to get left ventricular dilatation and was treated with an ACE inhibitor. A few years later, developed frequent ventricular premature beats and then was diagnosed with dilated cardiomyopathy. Now, the point about this example is that because this individual had a Lamin mutation and a nasty family history, prompt consideration was given to insertion of an ICD, and he also had an early heart transplant. So when we look at the 2017 guidelines for ICD implantation, it's interesting that at this point that LMNA was the first gene that was really added to the clinical diagnostic decision-making algorithm here. And since then, and over the last few years, there's been a lot of interest in other types of arrhythmogenic cardiomyopathies. And in particular, there's been this diagnostic grey zone between left dominant ARVC and arrhythmic forms of dilated cardiomyopathy. And in addition to LMNA, there's been a number of other genes that have been associated with these arrhythmogenic cardiomyopathies. So of note, by the time we get to the 2019 guidelines for ICD implantation, there are 2 more genes, filamin C and phospholambin, that have been added to the list of considerations for the timing and indications for ICDs. Now, as I mentioned, there's an enormous amount of interest in arrhythmogenic cardiomyopathies at the moment, and there are a number of centres around the world doing cohort studies and longitudinal follow-up of patients. So we're really understanding these diseases a lot more, and we can expect that over the next few years there may be a number of genes in addition to these genes that are added to the guidelines. And also there's likely to be changes in whether or not you need to have left ventricular dysfunction and what the threshold levels might be. So from what I've said so far, I think we can see that genetic information allows further information to be obtained about the potential timing and indications both for ICD and heart transplantation. I'd like to move it on now to a large family with arrhythmogenic cardiomyopathy, and we identified an R22Q SCN5A variant in this family, and the SCN5A gene encodes the cardiac sodium channel. So what was interesting about this family was that nearly everybody had ventricular premature beats. And this is a very characteristic ECG, which is really very abnormal, with a huge burden of ventricular ectopic beats and very few normally conducted beats. And you can see that the extra beats include narrow complex beats and also broad complex beats of left and right bundle morphology. Nearly half of the patients had ventricular arrhythmias, atrial ectopy and atrial arrhythmias, and nearly half the patients had dilated cardiomyopathy. So Jamie Vandenberg in our group went on to do some functional assays with cellular electrophysiology and showed that compared to the wild type channels, mutant sodium channels had leftward shift in activation and inactivation, which resulted in an increased window current. So this is a gain of function effect. And when we went back and looked at the family members, we found that family members who'd been treated with conventional heart failure therapies, shown in the red here, really had no improvement in their ectopy burden or in their ejection fraction. However, family members who treated with drugs that had sodium channel blocking activities, such as flecainide and amiodarone, had a dramatic response with a marked reduction in the number of ventricular premature beats and normalization of left ventricular ejection fraction. So this was a really fantastic example of precision medicine. We started with finding a gene mutation, worked out what the functional effects of that mutation were, and were able to give very targeted disease reversing therapy. Now, the story doesn't end there, and over the last few years, there are now 11 families in the literature with 73 carriers who've been found to have this same R22Q SCN5A variant. And in fact, this year, we found 2 new Australian families with the same mutation. And you can see here, looking at the clinical features, that all of these mutation carriers tend to have a very reproducible phenotype with a high burden of ventricular ectopic beats, atrial and ventricular arrhythmias, and about half the people get dilated cardiomyopathy. Now, over the years, other groups, in addition to our group, have looked at the functional effects of this variant and have found that not only does it increase the window current, but it also introduces a new gating port current. We'll come back and talk about that in a moment. Now, Stacey Peters, who's a PhD student with us, recently did a systematic review of the literature to look at all of the reported DCM-associated SCN5A variants. It was interesting because at the beginning of the story of SCN5A variants, it was pretty much thought that this was a loss of function disorder. However, when Stacey looked at the literature on this topic, it was found that a subset of variants that altered the window current or introduced a gating pore were actually the most common subtype of DCM-associated variants. And all of them had this very ventricular ectopy predominant arrhythmic phenotype that was very similar to what we'd seen with the R22Q. Now, this is a very important observation, which suggests that potentially the remarkable efficacy of sodium channel blocking therapy that we've seen with R22Q may in fact be relevant to a number of other types of cardiac sodium channel variants. So coming back to this question of what's going on, and our systematic review was quite informative about this. When we look at the cardiac sodium channel, the traditional kind of thinking about this, and particularly about gain of function mutations, is that there is a persistent increase in sodium current. And this has been associated with the long QT3 syndrome. But none of our family members, or pretty much none of them, had long QT3. And so there's something else going on. So here you can see the window current, which is occurring during the repolarization phase. And in silico models suggest that the effect of this window current, increased window current, is to increase the excitability of the Purkinje fibers, relatively more so than the surrounding ventricular muscle fibers. And so it's thought that this gives rise to the Purkinje source of ventricular ectopic beats. And one school of thought says that the dilated cardiomyopathy is the result of a high burden of these ventricular ectopic beats and arrhythmic burden. Then we come to this gating pore current. So what are we talking about here? This is a late sodium current. So here you can see in this schematic of the molecular structure of the sodium channel, there are 4 transmembrane domains, and the sodium normally goes through this central pore region. But in some of these transmembrane domains, particularly in the S4 regions, these red dots here indicate the location of the variants. What happens is that there is a new current is generated at the sites of the mutations. And this is cation selective, so it allows influx of other positive ions such as hydrogen, calcium, as well as sodium. And it's thought that this gating pore current alters the ionic milieu of the cardiomyocytes in such a way that it can depress cardiac function and predispose to dilated cardiomyopathy. So this is very interesting and provides new insights into potential mechanisms of dilated cardiomyopathy in this setting. So I'd like to come back to another family. So the index case here, this presented in pregnancy at 27 years of age with an irregular heart rate. And about 10 years later, she developed shortness of breath on exertion, frequent multifocal ventricular ectopic beats, and also junctional beats. And at that stage, she had a borderline left ventricular ejection fraction and was treated with beta blockers and ACE inhibitors. She had an electrophysiological study performed, and this showed multiple ectopic foci through the left ventricle, the right ventricle, and the right atrium. And it really sounded like a total nightmare from the electrophysiologist point of view. She had an ablation procedure and multiple sites were ablated. At that stage, her ejection fraction was 58%, and she had no evidence of ventricular fibrosis. Unfortunately, the frequent ventricular ectopy persisted. She had an ICD put in and went on to have 2 more extensive ablation procedures with multiple sites ablated. And she was also commenced on flecainide. And despite all of this, she still had a high burden of ventricular ectopic beats 18 months post flecainide. Now, at this point in time, genetic testing was performed and she was found to carry an R22Q SCN5A variant. Now, it's interesting to speculate if the genetic testing had been performed at an earlier age, soon after she presented, whether this situation would have been completely different and whether this whole saga of multiple ablations and hospital admissions and stress and worry may have been avoided. And certainly the take-home messages for this case are to recognise this very distinctive phenotype associated with gain-of-function SCN5A mutations and to think of early genetic testing. So the R22Q story adds a few more things to our list of how genotype can impact on management. And it offers the potential for genotype-targeted drug therapy, and genetic information may also potentially influence the indications and approaches for arrhythmia ablation procedures. Now, if we think about the differential diagnosis of SCN5A-related cardiomyopathy, there are a number of genes that we might think about. Obviously, lamin is one of these. The clues to lamin include the conduction defects and the high burden of atrial arrhythmias. The thing that really stands out as distinguishing the sodium channel variants is this multifocal frequent ventricular ectopy and its reversibility with sodium channel blocking therapy. Now, there's interesting new data emerging looking at MRI as a way to differentiate some of these arrhythmogenic cardiomyopathies. And as we mentioned previously, the SCN5A arrhythmogenic cardiomyopathies tend to have very little fibrosis, at least at the early stages. But there's emerging data to suggest that some of these cardiomyopathies, particularly desmoplakin and filament C cardiomyopathies, may be distinguished from other types because of a ring-like pattern of late gadolinium enhancement. So I think it'll be very interesting over the next few years to see what other information we might be able to use to distinguish and to recognize and distinguish these important arrhythmogenic cardiomyopathies. So when we're talking about precision medicine, we have to think about the individual patient. And of course, the focus to date has been on thinking about how a genotype might cause a phenotype. But in any individual patient, there's going to be a whole burden of rare and common genetic variants in the mix, as well as individual comorbidities, acquired factors, and lifestyle factors that may all contribute to the end phenotype. So we haven't got time in today to look into what all those modifying factors might be, but I think the point here is that genetic information helps us to pinpoint the patients with a high genetic risk who may potentially benefit the most from aggressive treatment of comorbidities and lifestyle factors. So where are we at in 2021? Looking back, we have seen a lot of disease gene discovery, new sequencing technologies, gene panel testing, and functional genomics. Where are we now? There's certainly expanded genetic testing options for our cardiomyopathy patients, emerging genotype-phenotype correlations, and we're starting to see therapies informed by functional genomics. Where are we going? Well, there's certainly a lot of interest in looking at cohorts of genotype patients to look at the natural history of disease, and hopefully we'll see new therapies for disease prevention and treatment and individually tailored management. What could some of this look like? Of course, there's going to be a bit of a trade-off between specificity, where you've got a targeted therapy to a single mutation that may be relevant to a single family, and scalability when you're talking about large numbers of patients. So things like the R22Q sodium channel story, there's a lot of effort for a small number of people. This is not going to be able to be possible for all families and all variants. However, there is increasing interest in looking at some of the downstream pathways that might be altered with some of these gene mutations to see whether there are common downstream pathways that might be targeted. And certainly in the laminopathies, there's a lot of interest in the MAP kinase pathways inhibitors, and there are clinical trials ongoing. And for sarcomere mutations, both for dilated cardiomyopathy and hypertrophic cardiomyopathy, there's interest in myosin activators and inhibitors. And I'm sure you might hear more about that from Caroline Ho in the next presentation. Of course, personalized lifestyle advice is very important. And then when we get down to this end of the triangle, I think there's going to be increasing reliance on deep phenotyping in genotype positive patients so that we can identify the very early signs of disease and also have a sensitive tool for monitoring disease outcomes. And hopefully in the very near future, we'll start to see clinical trials of interventions in various variant carriers, and hopefully with a focus on early disease. So precision medicine is not something that we just talk about. It is here. when we're talking about dilated cardiomyopathy. And I think the next few years are going to be very exciting times as we try and expand the scope and the spectrum of therapies that we offer our patients with dilated cardiomyopathy. I'd just like to thank the people in my group who've contributed to this data, and I'll be very happy to take any questions.
Fantastic, thank you. If you unshare your screen, then we will have a brief discussion just for a couple of minutes. So thank you for a fantastic talk, taking us right through from the very beginning as to where we've come over the last few years. So I get there is a question that is in the chat, which I'll bring up initially. So the question is, they're wondering if population genetics has a role to play, or whether personalised medicine is preferred, which is at more of an individual level in the diagnostic and treatment pathway of heart diseases. So what do you think? Do you think population genetics has a role to play, or do we think personalised medicine needs to be much more individualised?
Well, I think there is probably going to be a scope for both. And this is what the treatment triangle, if you like, at the end is all about. When we're talking about our families with familial forms of disease and we've got specific rare variants, hopefully we can increasingly understand what the functional effects of those are and potentially offer disease reversing therapies. But this is just not going to be possible for the hundreds and thousands of cases with familial dilated cardiomyopathy or familial hypertrophic cardiomyopathy or whatever. So I think we are going to have broad brushstroke treatments. And so that's when potentially when phenotyping might be important, or when there might be like with the laminopathies, where there may be downstream pathways that are applicable to a large number of mutations in the same gene, and then we may be able to have gene-specific therapies based on gain of function or loss of function. But I think we need to be practical, and probably for the vast majority of patients, we might end up needing to have better indications for when to start things like carvedilol-ACE inhibitors.
Yeah, that's, I mean, I find that a really fascinating point, actually, because, you know, should we be pre-treating early with ACE inhibitors, for example, to try and prevent downstream effects? And then there's always that uncertainty about, you know, does, as you say, does the ventricular arrhythmia or the ectopic burden really then propagate to LV dysfunction over time, which, you know, how do you try and intervene? How, you know, do you, what's cause, what's effect, etc. But I think where you've very clearly illustrated is that there's much work to be done, that we have to be mindful of both the family history. So it's absolutely critical that we evaluate the family history and think about the role of genetic evaluation. So in the heart failure arena, certainly in the UK, genetics aren't really thought about so early on, actually. Whereas in obviously the inherited conditions or cardiomyopathy world, it is very much at the forefront of what we do. So how we really scale the education to broaden the field, I think, is critical. It's interesting that you mentioned at the beginning about cost. It had been limited previously with Medicare reimbursements until more recently. So actually in the UK, it's much easier for me to perform a genetic test on the NHS than it is in the private sector, actually. So it's interesting, I guess, over time, as knowledge and awareness and appreciation of the role of genomics in this area grows, I hope that the uptake will be much higher. But as you say, a twitchy heart is not normal and should prompt genetic evaluation and certain consideration. Are there any other questions from the floor? Perhaps if I may ask you to pop it in the chat box. Was that one, sorry?
Actually, could I just, it's not a question, it's a comment on the previous question on the population genetics. It's a very important aspect. I think yesterday we talked about databases. We need to have more and more information on population specific variants and polymorphisms to interpret all VUS and all those novel mutations and also the phenotype in different populations. So that is for rare conditions. For common one, as you know, for common condition like familial hypercholesterolemia, we are moving at the population level, hoping to target the at-risk population. So I think, as Diana put very nicely, like a triangle, you start from the individual patient, then go to family, And from that family, you go to community and build up that base.
Absolutely, and the collaborative links to try and engage that so that across services we learn more quickly, and share our kind of data to really hone in on the genomics that are really helpful and important in driving this disease burden.
We have made success in the Genomics England, as you know.
Absolutely. Well, thank you very much. Thank you very much for your talk and sharing your insights with us. So I'm delighted to introduce our next speaker, who's Dr. Caroline Ho, and Caroline is the medical director of the Cardiovascular Genetics Center in Brigham and Women's Hospital in Boston, in the US. She's an associate physician and an associate professor of medicine at Harvard Medical School. So she has had a wealth of experience across the world of cardiovascular disease, and her research and clinical interests really focus on the diagnosis, research and management of hypertrophic cardiomyopathy. So if I may, I'd like to ask Dr. Ho to take us through novel therapeutic developments in hypertrophic cardiomyopathy. Thank you very much, Dr. Ho.
Well, thank you very much for inviting me to participate in this conference. It's a real honor and pleasure. And here are my disclosures for the presentation. And there are three big reasons why I think that you should care about hypertrophic cardiomyopathy. First, it's the most common cardiovascular genetic disorder, with 1 in 500 adults estimated to have unexplained left ventricular hypertrophy, and therefore potentially a diagnosis of HCM. Second, it's a clinically impactful disease with outcomes that are important to our patients and important to us. And then finally, HCM provides a remarkable paradigm where we can leverage fundamental understanding of the molecular basis of the disease to change clinical care. And as Diane had so elegantly just taken us through, seminal studies led by Dawn and Cricket Seidman and colleagues in the late 1980s and 90s really established the paradigm that HCM is a disease of the sarcomere caused by autosomal dominantly acting pathogenic variation in sarcomeric genes. Clinical genetic testing for HCM has been available since around 2004. And if we look at all comers with a diagnosis of HCM who are sent for genetic testing, about a third of the time will have positive genetic testing results, meaning identifying a pathogenic or likely pathogenic variant, again, almost always in the sarcomere genes. But if there's a family history of HCM and therefore an increased a priori likelihood of genetic disease, over 60% of the time, we find positive genetic testing results. And with HCM, more is not always better. Bigger panels or even expanding to the whole genome has not really led to a clinically actionable increase in yield. And the story really is quite predominantly in the sarcomeric genes. So that's where the focus tends to be. And looking at the breakdown of individual genes, disease is most prominently caused by variation in myosin binding protein C and myosin heavy chain, where collectively pathogenic variants in these two genes accounts for well over 80% of genetically positive hypertrophic cardiomyopathy. Mutations in troponin I and troponin T account for about 10%. And then there's rare variation in myosin light chains and tropomyosin and actin that round out the proportion of sarcomeric HCM. Right, and elucidating the molecular basis of disease has helped us better understand disease mechanism. And then we're very interested, of course, in understanding how we can use these mechanistic insights to improve clinical care. So here's one schema about thinking about disease pathways and current therapy in HCM. So we can think about the sarcomeric variant as being the initial predisposition. There are primary effects that we can identify in terms of hypercontractility, diastolic abnormalities, a profibrotic milieu, and impaired myocardial energetics. And these are all present in sarcomeric variant carriers even prior to the development of a clinically overt phenotype and expression of left ventricular hypertrophy. And then with the impact of age, genetic modifiers, lifestyle and other comorbidities, we can see secondary effects or clinically overt disease emerge with adverse remodeling and associated outcomes and symptoms. So right now, we very much treat this, I would argue, more end stage or advanced phenotype and focus on symptoms. So if there's LV outflow tract obstruction, we provide medical therapy or invasive septal reduction therapy. We try to assess risk for ventricular arrhythmias in our patients and appropriately provide primary prevention ICDs. If there's atrial fibrillation, we initiate anticoagulation and rate and rhythm control. And for those patients who are unfortunately develop advanced remodeling, we think about initiating guideline-directed medical therapy for heart failure and also potentially cardiac transplantation. So you can see that our current treatment really targets symptoms, and it's effective for many, but certainly not all patients. It starts relatively late in disease evolution. Historically, there have been no disease-specific or disease-modifying therapies, and there's very sparse evidence regarding efficacy. So a better understanding of disease mechanism is helping us to identify targets for therapy. And so normally, there's a very carefully regulated and carefully coordinated actin-myosin interaction through the chemomechanical cycle that leads to normal contractility and effective relaxation. So there's a very highly orchestrated attachment and detachment of the myosin head to the actin thin filament. Well, one model of HCM pathophysiology postulates that a primary manifestation of sarcomeric variants is that there are too many actin-myosin cross bridges engaged, so too many myosin heads interacting with the actin thin filament. And that leads to hypercontractility, impaired relaxation, and altered myocardial energetics, some of the hallmark features of HCM. So mavacamten is a first-in-class targeted allosteric inhibitor of cardiac myosin. It inhibits the first rate limiting step of ATPase that powers the attachment of the myosin head to actin to initiate the power stroke. And therefore, it reduces the number of myosin actin cross bridges and thus decreases the excessive contractility that's characteristic of HCM. And associated with this, there's also experimental evidence that it may improve left ventricular compliance as well as energetics. So mavacamten has been tested in phase 1 and 2 clinical trials, and then in the pivotal Explorer trial, which was released last year. So in Explorer HCM, 251 patients with symptomatic obstructive HCM were randomized, 123 to mavacamten and 128 to placebo. And they were randomized in a 1-to-1 ratio to receive either of these therapies for a total of 30 weeks. And you can see that the Explorer trial was largely representative of the overall HCM population with a mean age of 58.5 years. About 40% of the participants were female because these patients were required to have symptomatic obstruction. The majority of them were on background medical therapy, most prominently beta blockers. They were required to be either NYHA class 2 or 3 at enrollment, and the majority were NYHA class 2. And the baseline peak VO2 was about 19 milliliters per kilogram per minute. So the primary endpoint really focused on a functional endpoint because HCM is not typically associated with a high number of traditional major adverse clinical events or nor heart failure or hospitalization. We really focused on trying to identify a functional endpoint that was meaningful both physiologically and meaningful to patients. So a win was considered either achieving at least a 1.5 milliliter per kilogram per minute increase in peak VO2 and at least a 1-class improvement in NYHA class, or at least a 3 mil per kg per minute increase in peak VO2 with no worsening of NYHA class. And Explorer was positive with 37% of those on mavacamten versus just 17% of those on placebo achieving this primary endpoint with a between group difference of 19.4 and a highly significant p-value. There was also a secondary, more ambitious endpoint of achieving both at least a 3 milliliter per kilogram per minute increase in peak VO2 and at least a 1 class improvement in NYHA class, and 20% of those on MAVA, but only 8% of those on placebo achieved this endpoint. The patients on mavacamten had at least a 50 millimeter of mercury decrease in post-exercise left ventricular outflow tract gradient. So these are really quite substantial gradient decreases, and much more than we've ever seen in any other pharmacologic therapy, including beta blocker, calcium channel blockers, or even disopyramide. So this is almost surgical or alcohol septal ablation levels of gradient reduction. And because mavacamten is a myosin inhibitor, you can dial back contractility and dial back left ventricular ejection fraction in a dose-dependent manner. So a very careful eye was kept on the impact of left ventricular ejection fraction. But to achieve these substantial reductions in left ventricular outflow tract gradient, the dose required was had really quite minimal or modest impact on left ventricular ejection fraction, with an average decrease in LVEF of 4%. There was a small handful of patients that had a more marked reduction in LVEF below the protocol-defined limit of dropping below 50%, at which point mavacamten was held and there was recovery of EF. And mavacamten also had a very favorable effect on symptom burden, both in terms of improving NYHA class and also more broadly in terms of improving KCCQ score. You can see that here's where the Explorer trial fits, with a 9-point difference and 9-point improvement in KCCQ overall summary score. And that's, and to put this in context, this is where KCCQ scores, the level of KCCQ improvement that we see in other pharmacologic therapy of heart failure. So you can see that even in quite beneficial trials like Paradigm HF, DIAPA HF, and HF Action, there's a much more modest improvement in KCCQ score versus what was seen with mavacamten. And again, for context, these are the improvements in KCCQ score that we see with interventional therapies like mitral valve clipping and whatnot used in symptomatic heart failure. There are a number of remaining questions, of course, in terms of long-term safety and optimal dosing protocols. It's currently under FDA consideration, with formal review anticipated at the end of January 2022. And because of the potential beneficial impact of mavacamten on energetics and diastolic function, there's also been interest in whether it may be beneficial in treating the very challenging population of patients with symptomatic non-obstructive HCM. So Maverick HCM was a study, a phase 2 trial, trying to assess safety and feasibility in that patient population. So there were about 40 patients with symptomatic non-obstructive HCM randomized to 2 different dosing schema of mavacamten and compared to 19 patients receiving placebo. A treatment occurred over 16 weeks, and then there was a washout period to the end of study at week 24. So the Maverick study was not powered to adequately assess the functional endpoint that was used in Explorer, but there was an intriguing signal of potential benefit with a early and sustained decrease in NT-proBNP levels in those individuals on mavacamten, shown in the solid blue lines, versus placebo in the dotted line. So this was sustained throughout the treatment period and then increased back to baseline when the drug was washed out, suggesting that there may be some physiologic benefit from mavacamten in these patients. And there's currently planning ongoing for using mavacamten both in a larger population with non-obstructive HCM and also in HFpEF population in general. So there's a lot more action in the field. Mavacamten is currently being trialed in the VALOR trial, comparing mavacamten to invasive septal reduction therapy. Cytokinetics also has a myosin inhibitor that has recently received a name of aficamten, and the top line results of the phase 2 Redwood trial for symptomatic obstructive HCM using aficamten were released at the Heart Failure Society of America meeting last week, and so far quite encouraging. And then Novartis also has a trial ongoing testing the use of sacubitril valsartan in symptomatic non-obstructive HCM. So if we think about where we want to head in terms of future therapy for HCM, we have myosin inhibitors, which are already looking quite encouraging for the treatment of symptomatic obstructive HCM. But there's also, of course, great interest in trying to see if we can start the treatment clock even earlier. Can we achieve effective disease modification and potentially prevent the emergence of disease by treating early in the course? Myosin inhibitors in animal models have shown beneficial effects in terms of improving diastolic abnormalities and attenuating the development of left ventricular hypertrophy and fibrosis if given in the preclinical prehypertrophic phase. And similarly, calcium channel blockers and angiotensin receptor blockers also have given to mouse models of HCM prior to the development of an overt phenotype have also shown encouraging results in terms of attenuating the development of LVH and fibrosis. But of course, ultimately, when we want to go to the source directly and develop genetically targeted therapy that tries to counteract the effect of the sarcomeric mutation directly, and gene therapy approaches are currently in development. So, again, the ultimate goal is to leverage our ability to identify genetically susceptible individuals early in life before clinically overt disease is present, and then develop treatment that can prevent the emergence of disease altogether, or at least attenuate disease progression. But there are a number of challenges to this approach. First, how can we treat? We have to be able to identify and target key pathways. Whom do we treat? Disease may be mild or non-penetrant, so we really want to identify those who may be at greatest risk prospectively and target these more aggressive disease-modifying therapies to that group. And there are almost certainly going to be genotype-specific treatments, differences in treatment response that we need to better characterize and understand. We need to understand when to treat. Will lifelong therapy be required, given that the genetic susceptibility will persist throughout life? And then how can we monitor treatment? This is perhaps the most challenging piece in terms of developing clinical trials, because it's easy to figure out that you've made a sick person a little bit better, but to try to demonstrate that you've made a healthy person a little bit better is incredibly difficult. And can we actually detect relatively subtle treatment response? So studies on mouse models of HCM performed in the Seidman lab about a decade ago now identified that fibrotic pathways are activated early in life, prior to the development of left ventricular hypertrophy. And moreover, TGF beta activation appeared to be a central node. And treatment to inhibit TGF beta activation, either with neutralizing antibodies or with losartan, seem to attenuate the development of left ventricular hypertrophy and fibrosis. So here we see an untreated mouse with the myosin heavy chain mutation, and if allowed to age at about 30 weeks, these mice pretty reliably develop a phenotype of hypertrophy and fibrosis that you see in blue on this trichrome stain. But if treated in the preclinical stage with either the neutralizing antibodies or losartan, there's marked attenuation of both fibrosis and hypertrophy. And treatment was most beneficial when started early, before development of left ventricular hypertrophy. If treatment was not started until after the mice developed a phenotype, there was really no appreciable benefit. So these fundamental discoveries were the basis of the VANISH trial. This is the phase 2 randomized placebo-controlled double-blind clinical trial testing the use of valsartan to attenuate disease evolution in early sarcomeric HCM. So sarcomeric variants were seen at baseline and underwent active run-in to a goal dose of valsartan, which was the FDA maximal approved dose of 320 milligrams per day in adults and 80 to 160 milligrams per day in children. And those who successfully completed active run-in underwent stratified randomization and received valsartan or placebo in a 1-to-1 ratio for 2 years, study visits at the end of year 1 and at year 2 study end. So our inclusion criteria really try to focus on individuals with what we thought to be early stage sarcomeric HCM, because we were hopeful that this population would be more responsive to disease modifying therapies. So individuals had to carry either a pathogenic or likely pathogenic sarcomeric variant, had to be relatively young, between the ages of 8 and 45, to not have severe left ventricular hypertrophy, so maximum wall thickness of 25 millimeters or a Z-score of 18 in our pediatric participants. They had to be essentially asymptomatic and have non-obstructive physiology, and of course to be able to take an angiotensin receptor blocker. And in developing the primary endpoint, we carefully considered the challenges that we would face in demonstrating a treatment response in this young, healthy population, mainly that the magnitude of the impact of valsartan was unknown. Clinical events would be extremely rare, and the natural history in this cohort takes place over a very extended time course. The follow-up time of 2 years and the sample size, the targeted sample size of 75 individuals per arm, were really quite small to show impact. And so a standard analysis plan focusing on major adverse cardiac events was very unlikely to be successful. So therefore, rather than trying to show a large effect of valsartan on a single outcome, we aim to identify moderate effects in 9 metrics of cardiac structure and function, and really try to interrogate disease biology rather than these traditional clinical outcomes. The effect size was standardized as Z-scores, and we looked at the change between year 2 and baseline for each component, aligning changes to reflect consistently improvement and worsening. And so our primary outcome was a change in this composite Z-score at 2 years, with basically the average of the change of 9 individual change Z-scores. And I'll go over the components that we were looking at. So we were looking at biomarkers of myocardial injury and stress, including cardiac troponin T and NT-proBNP levels, where a decrease in the level over the treatment period would be considered success or improvement. Metrics of cardiac morphology, including CMR, LV mass, and LA volume, indexed to BSA, where a decrease in volume and value would be considered improvement. And then CMR, LV and diastolic and LV and systolic volume index. An increase in these values would be considered improvement, because at baseline, individuals with sarcomeric variants and individuals with HCM have smaller than average or smaller than normal LV cavity size. So an improvement more towards population norms for these values was considered improvement. And then also BSA adjusted echo maximal LV wall thickness, where a decrease was considered improvement. And then cardiac function was interrogated by looking at tissue Doppler E prime and S prime velocity, where an increase in value would be considered improvement. Here's our participant flow. 261 were consented and 200 and 19 entered into active run-in, with 212 ultimately being randomized. 34 were randomized to a preclinical exploratory cohort. So these were individuals with sarcomeric variants that did not have left ventricular hypertrophy or a clinical diagnosis of HCM, and they'll be analyzed separately. And here we're focusing on our primary analysis cohort of 178 individuals, 90 randomized to placebo and 88 to valsartan. So these are sarcomeric variant carriers with early HCM. We had 7 early terminations in the placebo group and 4 in the valsartan group, including 1 accidental death. And here are the baseline characteristics of the cohort. So the mean age was about 23 years. About 40% were under the age of 18. About 39% were female. And you can see here our Z-scores for maximum LV wall thickness were about 8, with a maximal LV wall thickness in terms of absolute millimeters of about 17 millimeters, with a slightly greater LV wall thickness in the valsartan group. The vast majority were NYHA class 1. And here are the results of the primary outcome. The study was positive, with a small decrease or worsening of the composite Z-score in those treated with placebo, but an increase or improvement in the composite Z-score in those receiving valsartan, with a between group difference of 0.231 and a Z-score of 0.001. And we also had pre-specified secondary endpoints looking at the individual components of our composite Z-score. And you can see that the improvement was most marked for NT-proBNP, LV end-diastolic volume index, and E prime velocity, with these 3 components individually showing significant improvement in valsartan versus placebo when adjusted for our confounders, but not when adjusted for multiple comparisons. Valsartan did not appear to be better in improving left atrial volume index or left ventricular mass index. And here are our pre-specified subgroup analysis, and it indicated that the benefit of valsartan was strongest in those with lower baseline left ventricular wall thickness. So below our median value of 7.3 as a Z-score, those with a smaller left ventricular wall thickness seem to have greater benefit, with a P for interaction of 0.04. Otherwise, the effect of valsartan appeared to be consistent across the remaining pre-specified subgroups. Relative improvement in the primary composite outcome was seen in males and in females, and in participants older and younger than 18 years of age, and with disease caused by variants in myosin heavy chain or myosin binding protein C. In terms of safety, there were no excessive adverse events. No instances of hypotension or hyperkalemia. The average systolic blood pressure decreased by 3 millimeters of mercury, and the average diastolic blood pressure decreased by 4 millimeters of mercury on valsartan. There was 1 participant in the placebo group, but none on valsartan were withdrawn by the site investigator for drug intolerance. So in conclusion, VANISH tested a novel strategy of disease modification in sarcomeric HCM, and specifically targeted early stage disease, which was potentially more responsive to pharmacologic intervention. Valsartan improved a composite outcome that integrated 9 metrics that reflected cardiac remodeling and structure function. Disease progression appeared to stabilize or potentially improve in those receiving valsartan, with the largest benefit seen in NT-proBNP level, E prime velocity, and LV end-diastolic volume. Treatment benefit also appeared to be greater in individuals with smaller baseline left ventricular wall thickness. This again supports our hypothesis that disease-modifying therapy may be most effective when administered early in those with less profound remodeling. And VANISH highlights an opportunity to attenuate disease progression in sarcomeric HCM with a widely available and well-tolerated medication. And then also on the horizon, gene therapies are in development, both in terms of allele-specific gene silencing genome editing, and then in haploinsufficiency models, as we see with myosin binding protein C, for the majority of pathogenic variants or truncating variants, there's also therapies in development for providing gene replacement therapy. So in summary, characterizing the genetic etiology of HCM can help guide management by identifying subgroups and informing prognosis. HCM cohort studies will further help to improve understanding of natural history and patient stratification. And we want to use this information to really transform our management, to determine factors that drive disease expression and prognosis, to identify clinically relevant subcohorts, and to develop rational mechanism-based therapy that will allow us to achieve effective disease modification and ultimately prevent the emergence of disease altogether and improve the care of our patients and families. So here's the home team and some of our important collaborators in the SHARE registry and also throughout the world. And here are the participating sites in the VANISH trial. So thank you very much.
Fantastic talk. Thank you very much. So, I mean, in the interest of time, I'm not going to take many questions on the actual floor. However, a really good illustration of bigger panels does not necessarily mean better evaluation, and I love the realm of thinking about prevention is better than a cure. I just wonder whether hypertension plays a really significant role, and the role of losartan in this cohort could be really powerful, perhaps even in those with genotype negative HCM. You've illustrated very clearly the kind of treatment options both for non-obstructive and obstructive HCM, so thank you very much. May I ask people to put any questions they'd like to in the chat box, and I'm sure Dr. Ho will help answer them for us, and I shall move on to the next session. Thank you very much to our fantastic speakers for opening this afternoon today. Thank you.
Good afternoon. I hope you can hear me. I think if everybody can mute, that'll be great.
There's quite an echo.
Yes, I think if everyone else mutes other than Eleni, that should be fine. Yes, so welcome to this excellent meeting, which is the sort of penultimate session of the VIII International Conference for Cardiovascular Genomic Medicine. We have three excellent speakers in this meeting. And the first person is Eleni Genola et al. She graduated from with a master's of computer engineering and informatics from the University of Patras, Greece. And then she went on to do a master's of philosophy in computational biology from Cambridge and a doctor of philosophy in bioinformatics from Oxford. She also undertook postdoctoral work at the Wellcome Trust Center for Human Genetics in Oxford and the Weatherall Institute of Molecular Medicine in Oxford. Prof. Genola et al. Joined the Victor Chang Institute of Cardiac Research in 2013 as a member of the Bioinformatics and Systems Medicine Lab, and in 2016 she started her research focuses on the development and application of statistical methods to answer genetic questions using high-throughput genomics data. Using the latest next-generation sequencing technologies, the team develops quantitative approaches to identify disease-causing DNA mutations and increase the current diagnostic rate of cardiovascular disease. So welcome, Professor Eleni Genola et al. And over to you to talk on genetics of spontaneous cardiac artery dissections. Thank you.
Thank you very much. Thanks very much for the nice introduction and for the invitation to speak today. Can you hear me okay? And you can see my screen? Yeah.
Yes, we can see you. Yes, we can see you and hear you on the slides.
Great. Thank you. So I'll talk to you today about our work on the genetics of spontaneous coronary artery dissection. And this is a collaboration with Professor Bob Graham from the Victor Chang Institute. So I'm sure you might know about spontaneous coronary artery dissection, but I'll just give a brief introduction for anyone who might not be familiar a lot with this disease. So it's defined as the spontaneous separation of the coronary artery wall that is not iatrogenic or related to trauma. And there's two suggested mechanisms that this might occur. And this is showing here the normal coronary artery. In this case, there is intimal rupture in initiating a tear, and that creates a hematoma. Whereas in this case, we have spontaneous bleeding into the arterial wall, creating a false lumen filled with intramural hematoma. So in both cases, there is a blockage based on the hematoma, and this is basically what's causing heart attack or sudden death. And it's an important cause of myocardial infarction, especially in young women. And in these women don't have any traditional risk factors, but usually they might have a scar episode during pregnancy, postpartum, or after emotional or physical stress. So although the mechanism is not clear, this disease has been associated with fibromuscular dysplasia, which is a condition characterized by abnormal cell growth in the walls of the arteries of the body. And there has also been an association with several connective tissue disorders, where patients with these disorders also have scar episodes, especially in Marfan and Ehlers-Danlos syndrome patients. So what do we know about the genetics of SCAD? So obviously, we know there's a genetic component because we start seeing a familial clustering. And then there is the first multicenter study that identified an association of an intronic SNP within factor 1. And this SNP is a known SNP. It has also been associated with migraine and fibromuscular dysplasia. And what has been shown in this large study is that in this SNP, the A allele carriers are shown to have an increased risk of a susceptibility for fibromuscular dysplasia or SCAD. And this is actually a disease that predominantly affects women, whereas the G allele carriers have a higher risk of coronary artery disease or myocardial infarction, and this is basically affecting more often men rather than women. And this is, as I said, it's a common SNP in factor 1, and factor 1 encodes a binding protein that interacts with both phosphatase 1 and actin, and is responsible for the regulation of actin cytoskeleton. So there's an implication that this factor 1 is a key component in angiogenesis. And there's been studies that are trying to characterize the function of this gene and its association with SCAD. And there has been also a suggestion that there is a trans effect. There's a study that has shown that there's a trans effect of this SNP with actually another gene, which is NPFL1, which is a SNP, with a gene that is 600 gay bases downstream of the index SNP. So apart from this first study, there's also last year has been 2 small-scale genome association studies. So I'm saying small scale because they were based on hundreds of patients rather than hundreds of thousands. But they both identified 3 main regions. One of them is the factor 1 SNP that is not really linked to any other loci, but there's also 2 more peaks that you can see here in the plots. And the first one is close to the ADAMTSL4 gene, which encodes a secreted glycoprotein that is localized at the extracellular matrix and is suggested that it plays a role in the integrity of the blood vessel wall. Interestingly, women demonstrate a higher basal expression of this gene, and the allele conferring the risk for SCAD is associated with lower expression of this gene, which implicates a hypothesis of relative deficiency of ADAMTSL4 involved in the mechanism of promoting arterial fragility. There is also a SNP in LRP1, which is a large multifunctional signal reception protein involved in many processes. And the same allele has been reported as a risk allele in migraine, cervical artery dissection, aortic aneurysms. And there's been a lot of functional work, and it has been shown that inactivation of LRP1 and smooth muscle cells of mice leads to an aneurysm formation an abnormally activated TGF-beta signaling pathway, which is the pathway often disrupted in connective tissue disorders. So apart from the GWAS study, there's also been 3 rare variant studies. So not a lot, but there's been studies looking for association of rare variants with SCAD. So the first one that I'm showing here was a study that performed a case control testing, and that was based on a set of 88, I think, cases versus controls, and they performed whole exome sequencing, and they did what we call a gene-based association test or a burden test and identify an enrichment of variants in TSR1. So this is one of the late-acting assembling factors that contributes to sequential Fourier subunit assembly. Not a lot is known about this gene, and it's at this stage, I think, it's more of a statistical association rather than having a clear mechanism of how it plays a role in disease pathogenesis. Apart from the TSR1, there was also a study that was a family-based study that identified rare variants in TALIN1, and that was based on this family pedigree, where assuming an autosomal dominant model with incomplete penetrance, the carriers, the affected and the carrier had a potentially pathogenic variant in TALIN1, which is a cytoscalar protein, and there's been studies that have shown that inactivation of TALIN1 in urine epithelial cells leads to defects in angiogenesis, and also a vascular disease phenotype has been observed in mutant TALIN1 zebrafish. There's also a study in a duo and a mother-daughter pair that identified a potentially pathogenic variant in F11R, which is a component of endocellular tight junction. So not a lot is known, and it hasn't been based on a bigger family, so we know for sure that that was the cause of disease. So in our work, we started performing whole genome sequencing in a cohort of SCAD patients, aiming to identify the cause of disease and anything we can with respect to the disease mechanism. So we have both families as well as sporadic cases. So we have a set of 15 families with SCAD, in total 52 samples, and we're looking for rare variants within families, but also looking across families for any recurrence in genes disrupted. And this is an ongoing work. We have a couple of good candidates that we're functionally validating. But today I was going to speak mainly about our work on the sporadic SCAD cohort. So this is a cohort of SCAD survivors that did not have an immediate family history of SCAD, but potentially other relevant disorders in their family. And we looked for both rare and common variants in this cohort. Because of the association of SCAD with connective tissue diseases, we looked for potentially damaging variants in both SCAD as well as connective tissue disease associated genes. We also tried to identify potential candidate novel genes that might play a role in SCAD etiology that could be good candidates for functional genomic studies. And we would also like to investigate the role of common variation as much as we can. And this is work that was performed by Ingrid Tarr in the group. So our cohort consisted of 91 unrelated samples. They were predominantly female and mostly of European ethnicity that had their average, had their first SCAD episode at about 45 years of age. About half of them reported chronic emotional stress, whereas 15% reported physical stress. And 46% had migraines, 28% had fibromuscular dysplasia, and only 2 had a prior connective tissue disease diagnosis. So we performed whole genome sequencing, and then we followed a bioinformatics pipeline that involves obviously identifying variants from the whole genome, annotating these variants, and then performing a variant prioritization. So to do this, we actually created a candidate gene list. So we had 2 tiers of our gene screen. So the first tier 1 list of genes consisted of 75 genes that were mainly genes that have been associated with SCAD, but also that are used for clinical diagnosis of connective tissue diseases or vasculopathies. And then we also had another 15 genes with a bit of lower confidence of their association with SCAD and connective tissue diseases. But we also looked across the whole genome. So in this case, we prioritize variants that are loss of function, that are novel, that haven't been seen in control populations, and also in genes that do not tolerate such variation based on gene intolerance metrics. So we applied the ASNG criteria of the American College of Medical Genetics, especially for the genes that we know mutations in these genes can be clinically actionable. But we also looked at other types of variation. We identified structural variants, and these are the bioinformatics software we've used for that. We looked also for splice altering variants. Given that we have whole genome sequencing data, we are able to look outside of the exons. As I said, we looked at loss of function mutations. And because obviously we have individual sporadic cases, we also performed a pathway enrichment analysis to look for any enrichment across the genes we identify across all our cases. And we also looked for short tandem repeats. This is kind of a separate type of variation, but there has been a couple of studies that have identified that women that have a fragile X premutation have the susceptibility of developing SCAD, and we wanted to see if our cohort did have any patients with short tandem repeats in this type of premutation. So in terms of the pathogenic variants we identified in tier 1 and tier 2 gene lists, so we were able to identify single nucleotide variants and indels that are classified as likely pathogenic or pathogenic in about 11% of our cohort, and that included 4 splice altering variants. We didn't identify any structural variation of interest. And this is interesting because, as I'm saying here, these cases have pathogenic variants, and especially in some of connective tissue disease genes without actually having typical symptoms of the connective tissue disorder prior to the SCAD anyway, or they haven't been diagnosed with a connective tissue disease. The majority of our cases had no interesting variants or had variants of concern significant, and we had a few cases that had variants that are heterozygous in genes that are recessive, autosomally recessive genes for connective tissue disorders. And this is an interesting point because SCAD is a little bit different. I mean, there could be an association of these heterozygous variants that might need to be investigated further. In terms of the differences in the clinical characteristics, we found that the variant carriers that we identified were younger on average than non-carriers. And as I said, we looked for loss of function mutations. We identified 24 loss of function mutations across the genome and across our cohort. And when we performed an enrichment analysis, we saw an enrichment of a TGF-beta signaling pathway, which we thought was an important result, given that this is the pathway that is often disrupted in connective tissue disorders. And these are all genes that are novel, that haven't been associated with this or SCAD before. Because, as I said, they are novel, there's not a lot of evidence. We need to obviously prove that they're related to SCAD. We were able to look at it in a separate cohort, and this is via collaboration with Dr. David Adler from the University of Leicester, where he and his group have performed whole genome sequence in a cohort of 384 SCAD survivors. And we've identified one gene that one of their patients also carried a loss of function variant. And not a lot is known about this gene, but we know it's involved in the novel folic acid biosynthesis. This is to be investigated further. And so I'd like to discuss a little bit. As I said, we identified a pathogenic or likely pathogenic mutation in 11% of our cohorts. And I'm not going to go into the detail of all these variants, but I wanted to give an example of one mutation, and that's in a COL3A1 gene in one male patient. So we identified a frame shift insertion leading to premature termination of the protein. So this is interesting because mutations in the genes are the cause of vascular Ehlers-Danlos syndrome, which can be particularly serious because of the risk of spontaneous arterial or organ rupture. And this gene is a very long gene. There's mutations across the whole length of the gene in all the exons that have been found to be likely pathogenic or pathogenic, and these are the different colors shown here for vascular Ehlers-Danlos syndrome. This is a gene responsible for producing chains of titrate procollagen, a major protein in the walls of blood vessels and hollow organs. So this patient, obviously, because we're doing this as a research study, was referred to a clinical diagnostic lab where they confirmed the mutation, but they also thought that he didn't have any clinical characteristics of Ehlers-Danlos syndrome upon follow-up. However, what we have found in the literature, but also following this case, is that variants leading to haploinsufficiency actually have been shown to result in a milder phenotype, limited almost entirely to vascular events. So interestingly, loss of function variants like this one potentially might only show a vascular event and nothing else in terms of symptoms of Ehlers-Danlos syndrome. And this is an example where actually SCAD is the only symptom or the only characteristic that would help this patient to get a diagnosis of a vascular Ehlers-Danlos syndrome. Apart from looking for a variant, variants in candidate genes, we also perform a rare variant association test or collapsing analysis or Venn test, as some people say. So basically, we didn't have a very big number. We only had 88 European cases out of 91 and performed a case control study, and we tested individual genes and gene lists. And obviously, because of a small number, no individual gene reached genome-wide significance, but we were able to compare and contrast with the validation cohort that I mentioned by Dr. David Adlam, and we identified one gene that is potentially worth following up, that is involved in calcium ion binding, that was also significant in that cohort. I mean, this is obviously we need the larger cohort to validate this, so this is a little bit preliminary at this stage. However, what is most interesting in our analysis that when we actually took all variants, not in a strict way, pathogenic variants, when we looked at missense and loss of function variants in our cohort that are potentially pathogenic, that have a predicted pathogenicity based on in silico tools, and compare like case controls, we found a high number percent of carriers in our cases versus controls across the gene, the 90 genes that we used. So that's showing that these genes are potentially associated with SCAD, although some of these genes were selected because they are known to be associated with connective tissue disorders. And then finally, we also looked at the effect of common variation in SCAD susceptibility. Obviously, some of our cohort might not have a monogenic cause of disease, but they might have an accumulation of common alleles, and that increases the risk of developing SCAD. And we used a 7-SNP genome risk code developed recently by the recent GWAS I mentioned earlier. We had a control, but also another cardiac cohort. And we were able to see very clearly that the genetic risk is higher in SCAD cases than controls or other cardiac disease patients. And this is showing that the majority of patients might not necessarily have a monogenic cause of disease, but they have an accumulation of risk alleles that might be what gives them the possibility of developing SCAD. So in summary, we identified connective tissue disease-associated likely pathogenic and pathogenic variants in 11% of our cohort. And some of them, as I said, didn't have symptoms of connective tissue disease prior to the study. And we propose that SCAD is potentially part of the phenotypic spectrum of connective tissue disease and may occur in people with subclinical connective tissue disease. As an example, I showed the male patient with the vascular Ehlers-Danlos syndrome mutation. And we also identified a new set of genes that may underlie SCAD pathophysiology. And as I showed, there is a potential functional overlap with a TGF-beta signaling pathway. But obviously, this is again to follow up. We confirmed the role of common variants in SCAD risk. And obviously, as I mentioned a few times already, we need a larger cohort to increase our understanding of the complex genetic architecture of SCAD. So this is a part of the work by a big SCAD team, and this is all the cardiology and a lot of the follow-up is performed by Bob Graham and his team at the Victor Chang Institute. And my group, we are the computational genomics and doing most of the bioinformatics and genetic analysis. So thank you very much.
Thank you very much. That was an excellent talk on SCAD genomics. And it's great to see that you are collaborating with one of our colleagues, investor here, David. So I'll start with my first question. I just wondered, is there any reason why 91% of the samples were from females? Is there any particular reason for SCAD? Is it much more common?
Yes, it's very, very common in women. We don't know why. I think there might be, and obviously that's a question more for my clinical colleagues, but epidemiologically, it's more common in young women with non-traditional risk factors, often during pregnancy or postpartum. So we think there's a hormonal component there that might affect the disease pathogenesis.
There is a question from Eleanor now. Eleanor?
Yeah, hi there. Thank you. So I was thinking about whether or not we should be pre-screening people, particularly women going through pregnancy, etc., because coronary artery dissection is much more common, particularly given the pressures during pregnancy. So I just wonder whether or not we should be using either some form of risk scoring in this sort of situation. And then the other element that I was mindful of is how do we engage our interventional colleagues to ensure that people that have coronary dissection or etc. is actually the penny drops, and that they think about considering these etiologies as a predisposition or as a cause of their acute presentation. I'm not sure whether it's so much a question as to whether or not what your thoughts may be on should we use this as a pre-screening tool, or at least ask the questions, the relevant questions.
Yes, I think I guess there is increased awareness more about SCAD now, and that's my understanding from my clinical colleagues as well. In terms of pre-screening, yes, I think it's a good idea. I feel like we have a little bit more to go though to understand more about the genetics in terms of being able to say we're going to do a genetic test. And it's interesting because we obviously didn't know a lot about the genetic overlap between SCAD and all the connective tissue disorders, but it makes sense because we see that epidemiologically. So I think asking the right questions about connective tissue disease as well is important to these patients.
Absolutely, thank you.
Thank you.
Thank you. I just wondered, is there any other questions from the floor? I cannot see anyone. Perhaps I could ask one more question, if that's okay. You said about Fragile X mutation and the prevalence of SCAD more in Fragile X mutation carriers. Any particular reasons for that?
Again, I think we don't know. We don't know, and I think there hasn't been. My understanding, there's only been a couple of studies that have shown that, and I think what we know now is that this is rare, but it's a little bit more frequent seen in SCAD patients than the general population. We didn't identify anyone in our cohort, but we had a small cohort, so maybe if we have hundreds and hundreds, we might see people that have the Fragile X. But I think there is a link, but we don't know why.
There is, thank you. There is a question from Karen.
Hi, yes, thank you. I'm a clinical geneticist and I've done quite a lot of genetic testing. Well, not a lot, but I've done a selected group of genetic testing in SCAD, normally where there's a family history or where a lady has had SCAD as well as a vertebral dissection or more than one spontaneous dissection. and I've not yet had a diagnosis. And I suppose one of my questions as a geneticist is whether or not, if a lady was found to have one of these variants, what clinical screening would we offer if a predictive test was on a family member? So Eleanor might be able to answer this, or one of the cardiology colleagues perhaps. And the other thing is, apart from explaining the etiology, which obviously is very important to these women, would a genetic diagnosis alter the clinical management? So I'm just trying to, because I keep doing these panels in these women and not getting an answer. And I'm just figuring out, should I actually be continuing? Is there a clinical utility here? Or am I just testing for no reason, really? So I'd really appreciate your thoughts.
Yeah, sorry. So you're using the connective tissue disorder panels, obviously.
Yeah, so mainly R101. If there's good reason. So, you know, like I said, if it's more than one event, if there's some family history, if there's features. So I saw a lady only in clinic this week who'd had SCAD as well as a vertebral artery dissection in the same admission, and has a family history of myopia and retinal tears. So and actually she's not sure whether she wants to have testing or not because she's so worried of a VIII diagnosis. So we haven't actually done it for her because she's really concerned about it and what it would mean for her children. But it's just really made me think about, actually, you know, if we do this test and we find something and then there's a child or a relative who wants testing, what are we actually going to offer these people? And that's where I'd really appreciate a cardiology thought on that, perhaps, because I think it's something we need to think about, perhaps.
I guess that's where, from my thoughts, the role of the interplay of blood pressure control, for example, a little bit like aortopathies, is there a preventative measure from that angle? But I'd be looking for evaluating the connective tissue disorders initially. And I mean, I think, again, this is where family history is really key, because if there's a clear-cut family history, then that kind of raises your suspicion. Whereas if there isn't, whilst you can keep it at the back of your mind, we've got to think quite broadly of the multifactorial elements that could play a role in this area. So I wouldn't jump to doing genetic testing, but I would be certainly aware of it and honing in according to, I guess, the potential risk parameters. But from a practical perspective, it's blood pressure control is one element that I would certainly consider. And if someone has had a scan at some point, then I again would be considering different variables at that stage. It's quite tricky. I think we open a can of worms, particularly if we open first degree relative screening for potential SCAD, and if we're not really clear of the phenotype and the actual etiology, I think it does open a bit of a can of worms.
Yeah,
further work's definitely required.
Yeah, and that's why I've only been testing a very selected group who've got very clear. There has to be a few features to really convince me to do it. So and still I haven't found a diagnosis in any of them yet. So
yeah. Maybe we're looking at the wrong things.
Quite possibly, yeah.
It's not, and even in the familial cases we have seen, there's never been a very clear Mendelian inheritance pattern ever. So it's very complicated. There must be more than, you know, a complete penetrant gene environment interaction. And yeah, you know,
I guess it kind of reflects the heterogeneity that we see in so many inherited cardiac conditions in general. So more work is required.
There is another question also very much related, again from a clinical geneticist, Ruth McGowan, to Eleni, where would you advocate genetic testing as part of standard clinical practice? And is there enough evidence for this?
I actually think we don't have enough evidence yet, if you want, because we initially were trying to find obviously the new SCAD gene that we didn't know about, but obviously we need to have a lot larger cohorts and maybe better recruitment of families. And we're looking at connective tissue disease panels, which I think as Carla also mentioned, she's testing for. But only a small percentage of the patients would have, we expect to see a mutation, really. Yeah, so I think maybe, yeah, we're not there yet, really.
Thanks, that's very helpful. I just wanted to say that my practice is the same as Karen's. Actually, I'm a clinical geneticist from Glasgow, and you know, to date, I've only really been doing testing on a handful of cases where there are either other indications or a family history. Interestingly, so I've only actually tested a handful of patients. Now, maybe it's just luck, but I have actually identified 2 individuals with vascular EDS through this, with pathogenic COL3A, a bit like certainly one young gentleman, age 30, who had a bit like the variant you described in your patient. And the only reason that prompted, he actually didn't have any family history. The reason that prompted me to go down the line of testing was he had a small scar in his chest wall, which had not healed properly. And he'd actually been to dermatology for this. He had absolutely no other phenotypic features, but he tried to get it removed, and it actually had said he'd made it worse. So I thought that was quite of interest, and that was what, you know, so yeah, so in the small number of patients that I have tested, I've actually had quite a big diagnostic yield, but I've been quite specific on who I've offered testing. But does make me wonder on, you know, am I missing cases, basically? So it's very useful to hear your talk, and it's very useful to hear what other people are doing, which sounds like it's very similar.
And then this male patient I mentioned, because he went to a clinical diagnostic lab, and actually he didn't get, although they found the same mutation, they didn't actually give him this diagnosis because they thought he didn't have enough. You know, the SCAD episode was not enough. You know, the phenotype wasn't agreeing. They thought he should have more than that. And it's interesting, actually, because in this case, I think that is, you know, having a vascular event when you're less than 40 should be enough to actually be classified as a vascular Ehlers-Danlos syndrome patient. But yeah, I think I see the chat discussion. I think being male is definitely a flag here, because we see this more often in women. So seeing a young man having a SCAD should be, you know, we should be testing more these males, I think. Yeah.
Well, the 2 ones that I've had gene positive have been male, so.
Males is always a red flag. Anyway, so moving on, because we haven't got Meena from Balasubramanian joining us at present. So we'll go on to our 3rd speaker now. Thank you very much for this wonderful discussion. So our 3rd speaker, who's coming second, is Professor Nimesh Desai. So Nimesh is a cardiovascular surgeon and an associate professor of surgery at the Hospital of the University of Pennsylvania. He received his medical degree from the Schlush School of Medicine in Ontario and his doctorate of philosophy in clinical epidemiology from the University of Toronto. He completed an integrated cardiac surgery residency at the University of Toronto and is a fellow of the Royal College of Surgeons of Canada. He was a member of the Surgeon Scientist Training Program at the University of Toronto and was fully funded by the Canadian Institute of Health Research. And he most recently completed an advanced surgical fellowship at Penn Medicine with an emphasis on minimally invasive valve surgery, complex aortic surgery, and endovascular surgery. And Professor Nimesh Desai is going to talk to us on genotype-driven aortic surgical interventions. Over to you, Professor. Thank you.
Thank you. I appreciate the opportunity to speak to everyone this morning. I've certainly learned a lot myself from hearing all these great talks. So this won't be as gene heavy as some of the talks that we've given, because I'm obviously a surgeon and not a geneticist, but I'll give you my perspective on how we think about aortopathies and in particular genetic syndromic aortopathies when we decide to do interventions, and some of the things that we worry about with these patients who are really complex and whose care really requires a lifelong of management, medical and interventional. So just to set some anatomic terms for everybody who may not be totally familiar with how we refer to the aorta. So the ascending aorta is obviously the part of the aorta that attaches to the heart. The arch comes across that after the innominate artery to the subclavian, and the descending past the subclavian, visceral segment, and abdominal. We also use a different classification of zones for endovascular repair, although that won't really be the focus of today's session. So what is a normal aorta? And that's an interesting question because, you know, for the vast majority of patients that I follow in my aortic clinic and that we follow here in our Penn Aorta Center, you know, that's usually the first question they ask is this abnormal, or what is a normal sized aorta? And there's a lot of things that go into answering that question. Body size plays a pretty significant role, and I'll talk about that a little bit later. And then which part of the aorta you're looking at, whether it's the root, which tends to be a little bit larger, the arch, and the descending aorta tends to be the smaller part of the thoracic aorta. Generally, we think any aorta greater than 4 centimeters is enlarged, and between 4.5 and 5 is typically where we start calling an aneurysm, depending on a bunch of different factors. That's an adult. Now you look at children, it's a whole different world. So the adult world, we usually measure based on CT, sometimes by echo. In the pediatric world, because almost all aortic aneurysms are in the ascending aorta, the vast majority, we typically, these are diagnosed by echo. And in children, we typically will index that to their body size and then develop a Z-score, so a number of standard deviations above the norm. For instance, if your Z-score is 3, that plus 3, then you're you know, in the top 0.1% of aortas for someone of your body size. And so that's how they're looked at in children. Typically, aortic aneurysms in the chest occur in about 1 in 100,000 patients, with the majority actually being in the ascending aorta. And just again, some nomenclature, a true aneurysm is when the entire aorta dilates. Pseudoaneurysm is when there's a break in the continuity and there's only adventitia on the outside. And then aortic dissection, which is the thing we worry about the most, is where the layers of the aorta come apart and you develop a sort of multi-channel aorta. And this is really what we're trying to prevent when we talk about aortic intervention, in particular in young patients with genetic aortopathies, is they don't typically rupture the way that abdominal aneurysms do. They dissect. And the reason they dissect is alterations in the media layer. So dissection is a very medial event. You know, these days we tend to blame the media for everything, but in the aortic world, we definitely blame the media because it is where most problems that happen in terms of developing aortic dissection start. And it's based on alterations in the elastin fibers and smooth muscle cells in the medial layer that create weaknesses and degeneration that eventually causes the wall to come apart. And this is what an aortic dissection looks like, both histologically and sort of in a gross specimen. You can see that the layers of the aorta have come apart. And this is from a sort of medial degeneration event where you lose the integrity of the strength of the medial layer. And I hope you guys can see this, but you can actually, in this picture here, in this video, you can actually see the intima of the aorta flapping in and out when you've had an aortic dissection. It's actually an amazing thing to see, terrifying too sometimes, but you actually see the tear. You can actually see how thin this aorta is in this young Marfan patient with an aortic dissection. And this is what an aortic dissection tends to look like. The most common version of this is a tear in the ascending aorta above the sinotubular junction or above the point where the aortic valve ends, the top of the commissures of the aortic valve. And you get flow into this false channel that then circles around and creates this double layered aorta with a true lumen flow, which is the correct lumen where the blood should be, and this really weakened false lumen. That was that see-through outer wall we were seeing in the last slide. So that's what aortic dissection is. And there's a couple of different flavors to how you can classify these, but Typically an A involves the ascending aorta. Those are the ones that keep me up at night. Type Bs tend to involve the descending aorta. We usually can manage those medically. Sometimes they're treated with stents. And then there's sort of acute and chronic definitions as well. So, but typically almost all of these start with the development of an ascending aortic aneurysm. And in our practice here at the Penn Aorta Center, and I think this is pretty common in most places, but as the genetics meeting, we know that there's a strong familial element to these, and in different jurisdictions, different reasons for developing aneurysms that can be more prevalent. Our most common is the non-syndromic, non-bicuspid familial idiopathic aneurysm that we end up operating on. Almost equal in commonality, though, is the bicuspid aortic valve syndrome, which has a genetic component to it as well, though very poorly understood. Then we get into the classic syndromic conditions, Marfan syndrome, Loeys-Dietz syndrome, ACT2 mutations, Turner syndrome, and a whole host of other ones that we'll get into as we go through the presentation. Atherosclerotic or hypertensive aneurysms that occur in the abdominal aorta, for instance, they're actually really rare in the ascending. We do see them in the descending aorta. They often have, older patients often develop atherosclerotic aneurysms, but really the ascending aorta in the 75 plus age patient, we see hypertensive aneurysms, but that's really it. We don't see it in younger people. There are inflammatory conditions and vasculitis that can cause it, like syphilitic vasculitis, which is really rare. Giant cell we see, very sporadically in our practice, but we do see it occasionally, and other iatrogenic causes of aneurysm formation. The actual, potential things that can be involved in dysregulating elastin, smooth muscle, and other elements of the extracellular matrix are massive, and I think we're learning an awful lot about them still. But this is just a small illustration of some of the targets that are potentially relevant in the development of thoracic aortic aneurysms. But we do know that they're very important. And we talked about clustering in different places. This is actually aneurysm mortality in the United States, fairly recent look at it. And if you look at the clustering, there's clearly regions of clustering, and they actually look very different than the clustering you see from other cardiovascular conditions like peripheral artery disease or coronary artery disease. So it's not just sort of lifestyle or dietary things that are happening in particular regions. There are clearly familial genetic reasons that aneurysms occur, and they do cluster within regions. Our region happens to be one where we see a lot of ascending aortic aneurysm, which is probably why we have a big aortic center here. When we look at that larger group, the one that I certainly see the most in my practice of non-syndromic familial aortic disease, I always think about two brothers that myself and one of my partners have taken care of over the last decade. And they really illustrate sort of how interesting and how little we know about this disease and how deadly it can be sometimes, or how dangerous it can be at least. So let's start off with the first brother in this family who we met, who presented with an acute type A dissection, actually had very severe malperfusion of his leg. So he couldn't, the dissection actually cut off the blood supply to the leg. So he underwent a complex aortic reconstruction. At the time, the aorta was under 5 centimeters. The root was not aneurysmal. The patient was otherwise healthy and had no family history that we knew of, that he knows of whatsoever, and had never been screened for aneurysm. So he had a successful repair. This is it here, actually required even some stents you can see in the iliac artery down there, so to treat the malperfusion. So very complex dissection, but he did fine, and we've been following him for several years. 9 years later, so that patient was 57, another 57-year-old male presents to us with an acute type A dissection, limb malperfusion. Very similar, very similar. Mean aortic diameter was 5 centimeters at the time of the dissection. It was under 5 centimeters, and the root was also non-aneurysmal, otherwise healthy, no known aneurysm. He's never been screened for anything, and had a successful repair. Now, when I followed him up in the clinic, and these were, the first patient was my partner's patient, this one was mine. When I followed him up in the clinic, he mentions his brother had emergency heart surgery years ago. And it turns out that these two patients were brothers. And, amazingly, they dissected at the same age with the same presentation, non-syndromic, non-bicuspid, non-aneurysmal, and we did a whole host of genetic testing and never found anything. We don't think these are environmental factors, that there's clearly a role here that familial hereditary issues are important, and we don't fully understand them. Optimizing the care of patients like this can be very complicated, because on the one hand, we know that there's clearly some familial component to it, but we can't tell them exactly what it is. And that's always very frustrating. So lots of science work to do in this area, for sure. The next most common group of patients that we see, and maybe this is actually the most common group in some practices, is the bicuspid aortic valve. So we know that BAV is present in 1 to 2% of the overall population. It's about a 2 to 3 male predominance, and there is a complex familial component to it as well, because prevalence is higher in first-degree relatives than the general population. About 20 to 30% of patients with bicuspid aneurysms, bicuspid valves rather, develop aneurysms in the first 10 to 20 years after diagnosis. Actually, almost 80% will eventually develop an aneurysm greater than 4 centimeters. They have an 80 times higher rate of aneurysm formation than the general population. Actually, in the United States practice, 50% of all root operations, so not just ascending, but root operations, some of which are being done primarily for valve problems, are for bicuspid valves in the patients under 50. So it's a very common reason that we're intervening. A lot of science going into trying to understand this, but there are two general theories, and I'll get into those in a second. But there are also a couple of different phenotypes of bicuspid aortic valve aortopathy. So the root phenotype, which is where the root dilates, but the ascending aorta is normal. So what we see sort of in the first panel here, we have very large dilated sinuses, but actually a pretty normal looking ascending aorta. That kind actually behaves more like Marfan syndrome. So we tend to operate on these early. These people tend to dissect early young in life, and we're very careful with those. And then there's the ascending phenotype, which typically shows up in people in their 50s, where the root is actually normal. And those people have a less malignant course, actually maybe even 3-leaflet aortic aneurysms in general. We think that there is a flow-mediated component to it, so it's not all a genetic aortopathy in bicuspid valves, that the way the bicuspid valve opens, it tends to force all of the blood out onto the rightward side, the lateral side of the aorta, and actually causes aneurysmal formation, and probably leads to a host of biochemical events and gene upregulation that eventually the shear stress can actually cause aneurysm formation. But still a lot to learn in that area, and we're not totally sure that explains all of the aneurysm formation. But there is also this other theory that the neural crest cells, which are the origin of the bicuspid aortic valve and the ascending aorta sinuses, alterations in their function may also be a cause of the aneurysmal formation in bicuspid aortic valves. The more classic syndromic genetic aortic conditions, and I'm highlighting Marfan and Loeys-Dietz, these are the ones that are the most well described and most common, are the ones that, although they're rare, even within our practice, are the ones that the patients we tend to worry about the most, because their aortopathy can be so aggressive. Bicuspid aortopathy, typically just in the root, you never have to worry about the rest of their aorta very much. Marfan, Loeys-Dietz, and some of the other aortopathies are really in a whole different realm of concern for dissection at smaller sizes, but also for late complications and recurrent aortic dissection or aneurysm formation in multiple different parts of the body. And they're so, although they're actually quite rare, they're often really complicated and require a ton of follow-up on our end. For Marfan syndrome, primarily a fibrillin-1 gene deficiency, which leads to medial degeneration and aneurysm formation. And about 80% of patients with Marfan syndrome will eventually develop a root aneurysm. And many will also develop mitral regurgitation. This is a great figure from this book, Endovascular Aortic Repair, that shows sort of the different perturbations that can be involved in Marfan syndrome, but obviously the one that I get really concerned about is the aortic root, but a whole host of other things, including chest wall deformities, mitral valve prolapse, pneumothorax, and very well described ocular and skeletal malformations as well. In terms of medical therapy for the Marfan patient, we know that both beta blockers and losartan have been shown to decrease the rate of growth of the aorta in these patients, although in a head-to-head trial, there was no real difference between using one or the other. And I think these days we often find patients on both therapies to try and prevent early dilatation of the root. And this is what a dilated Marfan root looks like. They get huge sometimes. This is probably a 10-centimeter ascending aorta. Normal for a person this age would probably be in the 3-centimeter range. You can imagine how big 10 centimeters is. It's just absolutely massive. These are, you can understand why these things tend to rupture or dissect at these sizes. And this is an operative picture of one of the ones that I've operated on previously, and you can see just how big and scary looking that aorta is. It's almost as big as the entire heart. Some seminal data that shows that repairing these prophylactically, even in the era when the surgery was really dangerous, was still better than waiting for them to dissect and then trying to repair them. And this is a paper from Vince Scott at Hopkins that looked at their series. This is actually a multi-center study of actually a large number of patients following and showing how much better patients did if you repaired them electively. And if you look at the emergency repair group, only the 50% survival is only about 10 or 11 years. So if you dissect your aorta, even if you get repaired and survive it, you tend not to do very well in life because the rest of the aorta tends to fall apart over time. So the idea is we really want to get to people before they dissect. And so this is the gold standard therapy. This is aortic root, we call aortic root replacement, or if you heard the word Bentall technique. This is done with coronary buttons. So you basically take the entire aorta out, you take the valve out, and you reimplant the coronaries in there with a valved conduit. And that's, until probably about 15 years ago, was a standard way of treating most ascending aortic aneurysms that involve the root. And Marfan and Low-Steats, for that matter, almost always do. Subsequent to that, Tyrone David in Toronto, who I had the privilege of training with, developed an operation where you didn't have to put a mechanical valve into these patients who are young and actually can experience a lot of late complications of anticoagulation. He developed a technique to reimplant the valve. So you can actually take out the entire Marfan aorta tissue, but save the person's own valve. And that valve could last for their entire lifetime. It could last 30, 40, 50 years without anticoagulation. And that's really changed how we look at these patients and why we're intervening on them earlier and earlier, because there's the risk of surgery, which in our hands these days is 1 or 2% mortality and stroke, maybe less than that in these really young patients. But the key is they're not being exposed to a lifelong need for anticoagulation anymore. So if they're in their 20s or 30s, they can live a completely normal life, be active, play sports and all those things, and not worry about being on Coumadin. And just here's some examples of why it's so important to intervene early, but also what the risks are in these people over time. So this is a patient who had actually was intervened on early. He had a mechanical Bentall root replacement, similar to what I'm showing you here. And years later developed this type B aortic dissection. I don't know if you can see this line here that's in the descending aorta. This is from an MRI, so it's a little bit harder to see, but there's that line there, and that is the dissected aorta. The smaller side is actually the true lumen. So Marfan patients that dissect, typically their aorta grows out very quickly. And, you know, this has gone from sort of a nice looking repair like the cartoon on the panel here to like an absolute disaster. And the patient eventually had an open repair of their descending aorta. That's this operation here. And then her arch blew out, and the descending, the abdominal aorta blew out, and she had 2 more subsequent operations to repair her arch and her distal aorta, and now has no more of her own aorta. So in some ways she's sort of cured of the aortopathy, but obviously had to go through 4 huge operations to get to that point. And it just stresses the importance of lifelong surveillance in these people. And this is sometimes what's really scary about this disease is this is a 50-year-old patient who actually never developed a root aneurysm, never needed surgery on that. They had surgery on their mitral valve earlier in life, but spontaneously developed a type B dissection without any aneurysm formation in their arch, ascending aorta, or descending aorta, all under 3.5. So, you know, it is a lifelong disease, and even patients who get into the older age group often develop late complications. Loeys-Dietz syndrome is obviously a newer syndrome that we're learning about, but certainly in my practice is the group of patients that concerns me the most. They are, first of all, the aortopathy is so aggressive that it presents in children. Even in young children can develop very large aortic aneurysms or develop aortic dissection. This is related to TGF-beta receptor problems, and there's actually 4 different subtypes. The first 3, TGF-BR1, 2, and SMAD3, are the ones that we typically see most often in our practice. These patients, you know, as an aortic surgeon, these patients are the ones that worry us the most because the aorta is so fragile and grows so quickly that it's really a very, very dire problem once patients start to develop dissections and things like that. This is the group we're also most aggressive with in trying to mitigate risk. So no contact sports, no isometric exercises, no strenuous exercises, no karate or boxing or anything like that. You know, these are patients who we really, really want to decrease the risk of any trauma to their aorta as much as possible, because they tend to grow into aneurysms very quickly. And this is the largest experience from Johns Hopkins. Typically their protocol, and we follow this protocol in the Loeys-Dietz type 1, 2, and 3 group, is we typically in children delay surgery until the annulus is large enough to accommodate an adult size graft, because you put something too small in when they're children, they won't, you know, it'll limit their growth and cause other problems. If the aorta ever hits 4 centimeters, we always operate on them. And if there are other morphologic features or the aorta is rapidly expanding, then it gets operated on early. We can get good survival in these patients out to 10 years, even 95%, if you do a lot of prophylactic surgery in them. But the key thing, and this is the 3rd panel here with the red circle here, at 10 years, even in patients who are primarily intervened on electively, half of the patients required further intervention on their aorta. So this is an extremely aggressive aortopathy. This is one of my patients that I've taken care of with this syndrome, who doesn't have ascending pathology yet, although we'll have to get to that at some point. They actually came in with a de novo type B dissection. She also has a cervical arch, which is a little bit complicated as well, but came in with an aortic dissection that grew from 28 millimeters to 43 millimeters in 3 months. And so we went for a very early intervention here and did a very large surgical repair to put it all back together again. So when should we prophylactically intervene on aorta? So our typical hinge points for non-syndromic aneurysms is somewhere around between 5 and 5.5. The risk of aortic dissection or rupture goes up dramatically around 5.2. And so between 5 and 5.5 is typically where we're intervening. Although those numbers are, again, different size people do have different size aorta. So these days we're indexing more towards people's height or their body surface area when we look at that. There's always nomograms that we can use to decide when to intervene on people. And also aortic length is becoming an important issue. So some of these tortuous aortas, like we see in Low-Steeds, for instance, the length of the aorta can potentially be very prognostically significant in determining the risk for aortic dissection. We know that family history plays a huge role in potentially causing or increasing the risk of aortic dissection, even in patients who are not syndromic and don't have any clear genetic cause. And so, the role of genetic testing in these patients is evolving. We have become much more aggressive about doing connective tissue disease panels and aortic syndrome panels in our younger patients. So if you've had aortic dissection under 60, you have a family history of aortic dissection, and in my opinion, family history of thoracic aortic aneurysm as well, or any kind of syndromic features, you should undergo genetic testing. Again, I think that our use of that modality is going up, although often we still get information we're not totally sure what to do with, and variants of unknown significance are the ones we really struggle with in terms of understanding it. But we're also very aggressive at screening family members, both with imaging and where appropriate, using this algorithm for genetic testing as well. So a very large area that we're still learning more about and getting more information on. If we try to actually develop a genotype driven surgical intervention, this is one of the proposed pathways to do this, where the TGF-beta genes, the Low-Steeds 1, 2, 3s, are intervened on a very small size, followed by things like Marfan and some of the ACTA mutations and PRKG1, which is sort of becoming a bit more commonly understood as well, between 4.5 and 5, and then the larger group we intervene somewhere between 5 and 5.5. So this algorithm is one that is a little bit complicated, but we do actually follow it. I think it's a good way to look at these patients. And again, the key is to really intervene on the patients with aggressive aortopathies early so they don't dissect. Once they dissect, their life expectancy and everything about their life going forward is going to be a lot worse. So in conclusion, I guess we look at this huge Marfan aorta. Genetically triggered syndromic aortic syndromes aortopathies are much more aggressive. And at least in our practice, we work towards timely intervention, close lifelong management of these patients, and in particular their families. And I think that's where, it's hard to integrate this kind of healthcare. We've developed a very large aortic center with a very interdisciplinary team with surgeons, cardiologists, geneticists, social workers, nursing, and a wide variety of different specialties, imaging as well, to follow these people. And it really does take a very complex infrastructure to really bring lifelong management to the care of these complex aortic syndrome patients. Thank you.
Thank you, Nimish. That was an excellent presentation on aortic surgical interventions. We have a national test directory for testing patients with rare diseases, and especially aortic ones. This is one of the most controversial ones, where we have an R125 score, that sort of testing. Especially we get a high result when there is younger onset, and as you said, syndromic features, and there is a family history. Yeah. So, and the last point which you said was very interesting on sort of genotype-driven aortic surgical interventions, and that slide was really, have you done any work on that part? The genotype can actually predict how the phenotype would be, and then you can do the sort of interventions based on the genotype.
Yeah, so again, I think that we have a fair amount of data on Marfan and Low-Steeds at this point. We are in the as we're putting our aortic center together, we're in the process. Dr. Piritz, who obviously you all know, was here for a long time, and his work in the area is extremely well known. Since he's retired this year from the professor emeritus position he had, we've been working towards building a whole new infrastructure to do that. And I think it's, but you're absolutely right. Like these, the thing that I think we're really, that if from a clinical practice is very interesting, is when you bring in a patient with an aortic dissection, for instance, and you operate on them, and they're young, and you talk to them, and they don't have any family history. There isn't really anything unexpected, but they're young, and you send them off for some genetic testing, and they come back as a fibrillin mutation and or a TGF-beta mutation or an active mutation, and you kind of understand like the clinical correlation between, wow, that aorta that I operate on was really, really like just like tissue paper and friable, and then you link it back to this genetic diagnosis. I think it's an important area, and one that we're certainly exploring along with a lot of other groups.
Thank you very much. I think in the interest of time, I think we'll move on. And if there are any questions for Nimesh, please post it in the chat box. Thank you, Nimesh, again.
Thank you.
So our next talk is by Meena Balasubramanian. And unfortunately, she's not here to present in person in Zoom. So we have got a recorded presentation of Meena. Meena used to be one of our registrars in Leicester many years ago when she was doing pediatrics. After finishing her training here in Leicester, she went to do her pediatric training and then on to her training in genetics at Sheffield. And she's been a consultant in clinical genetics at Sheffield since 2012. Her work has mainly been on OI, osteogenesis imperfecta, and she's led several projects focused on the genetics of rare bone disorders. And she's currently pursuing research projects focused on identifying novel genomic approaches to rare bone disease disorders and exploring newer targets for therapy for these conditions. And she's also pursuing a MRC fellowship on developing zebrafish disease models for bone fragility and developing targets for therapeutic intervention. So we'll try to put her presentation now. I don't know whether Neil, you're ready. Sorry, Nick, you're ready there? Yeah.
I'm Meena Balasubramanian. I'm a consultant clinical geneticist at Sheffield Children's Hospital, and I'm the lead geneticist for the highly specialized severe complex and atypical osteogenesis imperfecta service based in Sheffield. First of all, I'd like to thank the organizers for inviting me to speak today. The topic that I was given was to look at cardiovascular manifestations in skeletal genetic disorders using osteogenesis imperfecta as an example. So by way of introduction, what I would say is there are over 450 unique phenotypes when it comes to skeletal genetic disorders. And it is very important to make this diagnosis because it allows prognosis as well as being aware of what complications to expect and recurrence risk information. What's important to remember is quite a few of these skeletal genetic disorders.
Apologies, I'm just going to start that again with full screen where there's a couple of issues there. Bear with me.
Thank you, Lisa. I think perhaps you could start from about 2 minutes or something. Thank you.
What's important to remember is quite a few of these skeletal genetic disorders have very limited treatment options. Of course, osteogenesis imperfecta, which I will talk about, is an exception, as there are treatment options in the form of bisphosphonates. The diagnosis can often be difficult for the non-expert, especially because they are quite rare. And this is also because of phenotypic variability. We know with genetic studies that quite a lot of the what we thought were diverse skeletal genetic disorders are caused by the same gene. There's also variable expression as well as penetrance with these genetic disorders, and they are individually quite rare. Some of these have only had a handful of cases reported in the literature so far. But why does it remain important to study these rare skeletal genetic disorders? It's mostly to do with understanding the disease mechanism, because often there is overlap with common skeletal diseases, and understanding these rare skeletal disorders allows us to develop treatments for some of the common conditions, such as osteoporosis of the elderly. And there have been several examples of this in the recent past. So my focus as a geneticist has been on in-depth molecular phenotyping of such rare bone disorders. So bringing it down to osteogenesis imperfecta, this is an inherited disorder of bone formation. It's often described as the commonest form of heritable bone fragility. And if you look at the prevalence, it affects about 15 to 20 per 100,000 live births. And it's predominantly described as a type 1 collagenopathy. It's important to remember that there is a broad spectrum of clinical severity, ranging from multiple fractures in utero and perinatal lethality to hardly any features of normal adult stature. And if you look at the extraskeletal features, of which there are quite a few, this includes things such as dentinogenesis imperfecta, hearing loss, joint hyperextensibility, skin laxity, blue sclerae, etc. David Sillins and colleagues back in 1979 classified OI into what they thought were 4 distinct clinical subtypes. But this has exponentially expanded. And as a geneticist, I've been interested in studying some of the atypical and rare presentations of bone fragility. So if you look at the Sillins classification, they were all thought to be autosomal dominant pattern of inheritance, and type 1 was thought to be the milder form, where stature was normal with very little bone malformations. This was further subclassified into 1A or 1B based on the absence or presence of dentinogenesis imperfecta. Type 2 was the lethal form, which presented in the perinatal period with often adverse outcome, and this was thought to be autosomal dominant. But when recurrences happened, it was thought to be due to gonadal mosaicism, but now we know that quite a lot of the recessive conditions fall within this category. Type 3 presents with more severe short stature with progressive malformation of the long bones, and quite a lot of extraskeletal features as well. And type 4 is where you've got mild to moderate bone malformation with variable short stature. This is again subclassified into type 4A or B based on absence or presence of dentinogenesis imperfecta. This is a slide just to show that the Sillins classification has expanded, especially as the molecular basis of several of these different subtypes have become better understood. And of late, OMIM has over 19 entries in terms of the different types of OI in it. So I suppose the important question is, why does it happen? To understand this, we get into the genetics of it. We know that OI is mostly caused by variants within the type 1 collagen genes called 1A1 and 1A2, which accounts for over 85% of OI. COL1A1 sits on the long arm of chromosome 17, while COL1A2 sits on the long arm of chromosome 7. But both of these encode for type 1 collagen. And if you look at the type 1 collagen, it's made up of 2 alpha-1 genes, which is encoded for by COL1A1, and 1 alpha-2 chain, which is encoded for by COL1A2. So essentially, if you look at this slide, you've got these collagen fibrils that are introduced in a staggered pattern as seen at the bottom of the slide. And we know that different collagens are present in the same fibril and are needed to form these fibrils. So there are a number of different genes which are involved in making these proteins come together to form the fibrillar collagen, and it will be the same for type 1 collagen. And if you look at the top, the initial amino acid sequence consists of a glycine followed by XY, any different type of amino acid, followed by a glycine, and so on it goes. So glycine helps form the structure known as the triple helix, with which these three chains become intertwined. And these chains are then linked together to help form the collagen fibrils that we see under the electron microscope, which I'll go on to show. What's important to remember is it's not just the type 1 collagen genes. There are quite a lot of genes that are involved in post-translational modification and processing of collagen. And interestingly, these are the genes that are known to be associated with some of the rarer forms of OI. So this is an example of an electron microscopy showing collagen fibrils in normal skin. And you can see on the longitudinal section, as well as the transverse section, these collagen fibrils that are quite tightly packaged together and appear uniform in shape and size. And this is what you'd expect to see in normal skin. You can see what happens when there's pathogenic variants in the type 1 collagen. So this is an example of a qualitative defect in one of the genes encoding for type 1 collagen, where the triple helix formation is not as tightly as you'd expect, and hence this is abnormal, resulting in bone fragility. So bringing it all back to genetics and bone fragility, as I've explained before, over 85% of patients have got pathogenic variants in COL1A1 or COL1A2, which follows an autosomal dominant pattern of inheritance. And we know with a specific type of OI known as type 5 OI, which is characterized by intraosseous membrane ossification and hyperplastic callus formation following fractures. It's often caused by a recurrent variant C-14C to D in IFID M5. But there's another recurrent variant in IFID M5, a serine to leucine change, which overlaps with the type 6 OI, where it's characterized by fishbone lamellar appearance on the bone biopsy. But then there's several recessive forms of OI, as you can see, including genes involved in post-translational modification of collagen, CRTAC, P3H1, and PPIB, as well as several of the recessive rare forms of OI as described here. There's a lot of work being done on the Wnt beta-catenin signaling pathway, and interestingly, heterozygous variants in Wnt1 have been described in association with osteoporosis, while homozygous or compound heterozygous variants in Wnt1 have been associated with a more severe form of bone fragility and neurological phenotype. Same with LRP5, heterozygous variants have now been reported in association with osteoporosis, whereas recessive variants in LRP5 causes this condition known as osteoporosis pseudoglioma syndrome, OPPG. There have been a few newer autosomal recessive genes being described, but these are extremely rare, with only a handful of cases reported so far. And then previously, there was a rare OI syndrome known as Cole-Carpenter syndrome, which was thought to be phenotypically quite distinct and similar. But we know that two different genes causes this SEC24D and P4HB. And just when you thought the genetics of bone fragility only had autosomal dominant recessive forms, came along a couple of X-linked forms of osteoporosis with fractures. I suppose you wouldn't label them as OI, but they still cause significant bone fragility. This includes PLS3 encoding plastin-3 and MBTPS2. And then I've made a list of some of the rarer genes that are known to cause OI, which have been described in the last couple of years. But what's interesting is, as some of the newer genes are described, they seem to have overlapping phenotypes where they often present with OI and other things such as seizures or intellectual disability. So I thought I would just give you a flavor of what we phenotypically expect to see in OI, assuming at least some of you may not have seen children or adults with osteogenesis imperfecta. So this is a little boy whom I look after, who's got a glycine substitution in COL1A1 in the proximal part of the gene. You can see his sort of bluish gray appearance to the sclerae, and he's got significant joint hypermobility along with his fracture history. And these are some of his X-rays, which show the presence of osteopenia, but also these striking bisphosphonatal lines from being on treatment. This is his skin biopsy, which shows the presence of these collagen fibrils, which are perhaps not as tightly packaged as you expect, but also these very striking looking collagen flowers, which are an amalgamation of abnormal collagen fibrils. Although they're not pathognomonic of OI, they are quite an important finding when seen to support diagnosis. This is another little lad with a splice site variant in COL1A2. So this results in a quantitative defect in type 1 collagen. And you can see he's got significant short stature, but also this very striking bluish gray appearance to his sclerae. And again, his X-rays also show the presence of osteopenia. This is another little lad that we look after who's got a COL1A1 variant with a similar phenotypic. He's got an S-shaped scoliosis, which has got worse over the years, but also this striking collagen flower on his skin biopsy. So this is just a snapshot to show a study that I'd recently done looking at in-depth phenotyping in patients with OI. We showed these sort of abnormal skin biopsies, including the presence of these collagen flowers. So bringing it all down to the cardiovascular phenotype in OI, what do we already know? What's known is that there is an increased risk of cardiovascular disease, but it is not one of those conditions such as Marfan syndrome or Ehlers-Danlos syndrome, where there's a big part of the phenotype. And like I say, the cardiovascular risk has been known for years, but the precise spectrum and incidence have been poorly described. And most of these have been confined to single case reports or small cohort studies of population with OI where they have found cardiovascular disease. But interestingly, if you look at the mouse model data, it points to direct effects of OI on the cardiac system in mouse models such as AGA2 and OIM. So why does it happen? Comes as no surprise because collagen type 1 constitutes about 80% of total collagen in the myocardium. And we know that 80 to 90% of aortic collagen is type 1 and type 3. Collagen fibers in the ventricular myocardium contribute to tensile stiffness and help maintain myocyte architecture. And it's thought that the valvular involvement in OI could be due to biomechanical differences. When you look at the aortic dissection, this is thought to be due to mechanical weakness secondary to abnormal type 1 collagen. So what do we know about the cardiovascular features in OI? Increased incidence of valvular heart disease is perhaps the best established cardiovascular risk factor. Aortic and mitral regurgitation are thought to be the commonest valvular insufficiencies when it comes to OI in the adult population. But interestingly, tricuspid valve insufficiency appears to be the most common manifestation when it comes to pediatric OI. And if you look at the literature, of 70 published OI patients, they're predominantly aortic regurgitation followed by mitral valve insufficiency. What about aortic dissection in OI? There's only a handful of case reports again of aortic dissection in OI. The first description in OI was in 1993, followed by 5 further case reports that were published. And then we published the series of 4 more patients with aortic dissection last year. And mostly we know that this is associated with the milder form of OI, so-called type 1 OI, which is often as described as type 1 collagenopathy. So if you look at what's been published in the literature, mostly these were in the 1990s, of course, with a couple of case reports more recently, but they were all in males and they all had a mild type 1 OI, and they all had mostly the common form of aortic dissection. In our series, of course, we were able to describe 2 females with aortic dissection. Again, one of them had aortic and mitral valve disease previously and needed an aortic root replacement. This was the first such series where we were able to describe molecularly confirmed OI in our patients, although the 42-year-old female does not have a molecular confirmatory diagnosis, although she phenotypically does have type 1 OI. So this was one of the first series that we published where females were shown to also be at risk of having aortic dissection in the context of OI. So what about the risk factors? When you look at aortic dissection based on data from the International Registry of Acute Aortic Dissection, You can see that there are the common risk factors, including being male, age, pregnancy, cocaine use, hypertension, having prior cardiac surgery or aortic dissection, or cardiac disease, atherosclerosis, diabetes, hereditary connective tissue disorders, of course. But if you look at the risk factors in association with OI, they are very similar. You've got males more than females. Type 8 dissection is commoner across both groups. And like I said, the series that we published had molecular confirmation, but none of the previous case reports had molecularly confirmed OI established in their patients, although phenotypically they were all described as having OI. What about aortic dilatation in OI? Now, this has more robust data. Several studies have suggested enlarged mean aortic diameter corrected for body surface area in both pediatric as well as adult OI. And so it would suffice to say aortic dilatation appears to be the most common OI-associated cardiovascular manifestation. Interestingly, most of the literature seems to come from targeted screening of healthy OI population rather than those that presented with disease. And it's also thought that the more severe form of OI, the more the chance of aortic dilatation, which doesn't come as a surprise. What about risk of cardiovascular disease in OI overall? There was this extensive Danish-based cohort study on OI done by Lars Fogstad et al. In 2016. And this is the largest cohort study on cardiovascular disease in OI. So it's a nice paper if you'd like to read that. Essentially, what the authors concluded was there was an increased risk of mitral and aortic valve insufficiency, heart failure, atrial arrhythmias, including atrial flutter and atrial fibrillation, even after correction for known risk factors in individuals with OI. And what they recommended as cardiac follow-up was ECG in adults, as well as echocardiography from the age of 50 years in this group of patients. So moving on to rare OI syndromes, having discussed all about the cardiovascular manifestation in the more commoner forms of OI, the type 1 collagenopathy. I must confess, I haven't seen much of a cardiovascular phenotype when you look at the some of rarer OI genes. One of the stats is, of course, TMEM38B, which has been described in association with type 14 OI. What we know is that some of these patients at least have a founder effect variant. They're homozygous for a point mutation in exon 4 of TMEM38B. And if you look at the phenotype in this group of patients, they seem to have a cardiac presentation with young myocardial infarction, muscular hypertonia. They also seem to commonly present with septal defects and hypertrophic cardiomyopathy. So I always say to the trainees, think of this if patients present with bone fragility, but with added cardiac or neurological features. You can see compared to some of the rarer OI genes, TMEM38B encodes for TRIC, which is involved in intracellular calcium signaling and hence lends itself quite well to this sort of cardiac presentation. So that is mostly the cardiovascular phenotype in association with OI. But what about some of the other skeletal conditions? Variants in N-terminal helical region of the type 1 collagen genes have been known to result in a phenotype overlapping OI type 1 and Ehlers-Danlos syndrome. And of course, this is associated with valvular heart defects. Spondyloepimetaphyseal dysplasia, joint laxity type caused due to variants in B3-GAL6 are associated with patent ductus arteriosus and valve defects again. Some of the overgrowth syndromes, such as Soto's, Simpson-Galabi-Bemel syndrome, Weber, are all associated with congenital cardiac anomalies. The short-trip polydactyly syndromes, which often results in a more perinatally lethal skeletal dysplasia, have also been associated with cardiac anomalies. And Marshall-Smith syndrome, caused due to pathogenic variants in NFIX gene, are known to be associated with septal defects. So these are some of the commoner presentations of cardiovascular phenotype in association with a skeletal genetic disorder. So what about cardiovascular screening in OI? We recommend 3 to 5 yearly echocardiogram in adults, but of course always follow up with a baseline cardiac assessment at the time of diagnosis. And what we always say is larger studies on prevalence of cardiovascular phenotype in OI is sorely required. What's interesting is on the back of our aortic dissection paper, I started screening quite a lot of our adult patients with OI for clinic and found that apart from a handful of bicuspid aortic valve and incidental valve insufficiencies being picked up, it didn't actually result in any great cardiovascular manifestations. So it perhaps is not a greater part of the phenotype in that sense. So to summarize, I hopefully have given a good understanding of the basic terminology that we use when it comes to OI, a bit of the description on phenotype, covered the cardiovascular presentation in OI and provided a literature overview of the cardiovascular manifestations in skeletal conditions, including and more specifically OI, but also a bit on the screening and surveillance that we would normally recommend. Thank you for your attention. I'm happy to take any questions or of course be contactable by email. Thank you.
Thank you, Nick. Thank you very much. It was an amazing session where we had three brilliant speakers, Nimesh, Eleni, and Meena. So if there are any questions for Meena, please either email us or you could always email Meena directly. So thanks a lot for listening, and I will hand it back to Devendra. And I think we are going for a short break before the next session.
Thank you, Pradeep, and thanks a lot for all intercontinental speakers. It has been really fascinating presentation touching the therapeutics element of our conference. We'll have a short break for about 10 minutes and we'll be back. Dr. Neha Sekhri will be the chair, and Professor Seema Mittal from Hospital for Sick Children in Toronto is making a presentation. I think it will be another recorded video talk presentation. So please join us. Thank you very much.
Are we ready to start?
Yes, I think waiting for Nick, Lisa to kick off the recording video. But
Fantastic, thank you. I'll perhaps take the opportunity then to introduce the next speaker. It is a recorded lecture, but it gives me great pleasure to introduce to you Professor Seema Mittal, who is the head of cardiovascular research at the Hospital for Sick Children. She's also the principal investigator for the Heart Center Biobank, which is one of the world's largest biorepositories for childhood onset heart disease. She's a professor of pediatrics at the University of Toronto, and Dr. Mittal's research targets include precision medicine, including genomics and pharmacogenomics and stem cell applications to model childhood heart disease and discover new therapies. I'm led to believe that the topic of presentation today is more on AI and genomics, and I, alongside you, look forward to hearing more insight into this exciting field of medicine. Likewise, any questions, please do post them in the chat room or feel free to contact Professor Mittal directly. Thank you.
actually, Professor Mittal has joined. I can see her.
Oh, brilliant. There you are. Hello.
Hi. I would still prefer to just have the recording done if that's a recording presented, since it's already done that way, but I appreciate the great introduction.
You're most welcome to give a live presentation if you can manage.
I think Nick said he would be able to just project the video, and I'll be here to answer questions for sure.
Perfect. Welcome. Thanks very much for that.
Thank you, Dr. Kumar and the organizing committee for giving me an opportunity to talk about the advances in cardiovascular genomics, which was a broad topic, but I decided to focus on artificial intelligence application in genomics, partly because this seems to be the way of the future, and we have started making forays into applying some of that in our own genomic studies. My disclaimer is that I am not an expert on AI, therefore I won't be talking about the technicalities of the programming behind AI, but we'll be giving you more of a 30,000-foot view of AI applications in genomics. And I will refer heavily to a 2019 paper by Diaz and Torkamani in Genome Medicine. This is maybe not a 30,000, but close to 30,000-foot view from a Cessna in August of this year, where I had the privilege of visiting the Yukon, which is one of the northern territories in Canada. And this is a flight to Mount Logan, which is the tallest mountain peak in Canada. And that's how beautiful it looks when you're looking at it from afar, where everything that went into the making of the glaciers is probably hidden. Anyhow, so the talking points will be a little bit about the basic types of interpretation tasks for AI that can be applied to healthcare and to genomics and their applications, as well as just a very little at the end about the challenges and limitations about AI applications. So at a very simple level, what is AI? What is artificial intelligence? Artificial intelligence is where you have machines or computer systems that can perform tasks that normally require human intelligence. It doesn't mean that they are completely independent, because the input still requires human knowledge to be inputted, as well as the output still has to be interpreted by the humans. An important feature of AI is deep learning. And so what is deep learning? Deep learning is AI algorithms that learn interpretable features from large and complex data sets by using neural networks, which are basically a network of artificial neurons and nodes that can speak to each other. So for an AI algorithm to work, it requires an input, which is the basic or fundamental unit of input, which, for example, for images can be the pixel intensity. For healthcare records, it could be the EMR diagnostic codes. For genomic interpretation, it could be the DNA sequence. This data input then goes to a layer of nodes or neural networks that deconvolute and reassemble the data in order to develop an algorithm that allows them to interpret what is asked of for them, and that interpretation task is provided as an output. There are many types of interpretation tasks, and these are the algorithms that are used in order to perform those interpretation tasks, like computer vision, which is essentially image recognition. And as you know, we can apply it these days to reading radiology or pathology images. Time series analysis is where there is interpretation of continuously streaming data like ECG data for diagnosing atrial fibrillation. Speech recognition involves, again, a recognition of language, and but more importantly, the tenor or the quality of the speech, and this can be used to detect neurological disorders. And then there's natural language processing, which relies on extracting data from human language, either structured or unstructured. And this can be very useful for clinical diagnostics when trying to use data that exists in electronic medical records. So I'm going to talk a little bit more in detail about how each of these can be applied to healthcare and to genomics. So when you think about computer vision, typically used, for example, for facial recognition, in a computer vision algorithm, the algorithm is trained on images. So let's say these are various facial images that are given as an input to the algorithm. The algorithm learns to detect edges in an image. It learns to detect patterns of these edges that represent shapes. And then it learns to interpret the collection of shapes that resemble objects, so that by the end of it, there is an algorithm so that when you feed a new image, the algorithm is able to recognize what that image is about, and maybe even recognize the identity of that person. How is it used in clinical diagnostics? One of the earliest FDA approvals given to AI applications was, in fact, for interpreting medical scans. And these scans can be MRI, where you can use AI to quantify blood flow through the heart, to quantify ejection fraction on echocardiography, to detect stroke or hemorrhage on head CTs, to identify the diagnosis or cell types in whole slide imaging on pathology, and for automated classification of dermatologic conditions. FDA has also approved tissue diagnostics, where AI can be used in lung cancer histopathology to identify cancer cells, their type, and that can be used to predict the somatic mutations that might exist in that tumor. And then, of course, there is the strong field or area of phenotypic diagnostics, where you can use facial image recognition to identify disease. An example of that is in this study, where they used, in 2019, this was published, where they used facial phenotypes and used AI to diagnose genetic disorders using a deep learning algorithm called Deep Gestalt. Now we know that facial abnormalities or facial dysmorphologies can be of over 1,000 types. There are over 1,000 HPO terms for facial abnormalities. These are associated with over 4,500 diseases that involve over 2,000 genes. It is just not possible for even the most experienced clinical dysmorphologist to carry all that information in a way that that when they see the patient, they are able to pinpoint the disorder. So what this program did was they trained Deep Gestalt on 17,000 images of patients which represented over 200 genetic syndromes. And when they were, after developing the algorithm, when new images were fed to the program, there was a 91% accuracy in identifying the correct syndrome on these 500 plus images. These are the different syndromes that you can see listed here. They went a step further, where they further trained their algorithm or their Gestalt model to identify the different subtypes of rhizopathy. So these are different patients with different mutations. The software did not know what the mutations were, but they were able, with 64% accuracy, to identify the different rhizopathy subtypes. And this, in fact, outperformed human dysmorphologists who were not able to distinguish these subtypes. And in fact, they went further, and when they incorporated in the Deep Gestalt the genome interpretation system, where you added what genetic variation was identified in a given patient, that particular program or software called PEDIA was able to identify or pinpoint the genetic syndrome with even greater accuracy. What about time series analysis? Time series analysis is used to process temporal data to forecast future observations. And it's used in daily life to predict stock prices, to predict weather, to predict geological events. What about application in the clinical or cardiology world? This is being most commonly used now for analysis of data that comes from smart wearables that are used for cardiac monitoring. And this is one example of an FDA-approved device called AliveCore, where you can put your fingers over a sensing device for 30 seconds, and that will capture the ECG and transmit it to a central interpretation location, where AI algorithms will be able to differentiate between normal rhythm versus atrial fibrillation versus presence of PVCs or SVT and even white QRS, all of which actually has been FDA approved. And there are many such devices or smart wearables that are coming along. What about automatic speech recognition? This involves recognizing the quality or the timbre of the speech, and we use this again on a daily basis when we use voice call dialing. It can also be used for recognizing speakers and even speaker verification. For example, in a Zoom meeting, you could use that to verify that this is the speaker or the identity of the speaker. How about in medical or in clinical care? Automatic speech recognition is beginning to be found to be quite useful for detecting neurological conditions like Alzheimer's or Parkinson's or even PTSD, where the quality of the speech differs from that of a healthy individual. And this type of pattern recognition allows AI to actually diagnose or detect these kind of disorders with pretty good sensitivity. And finally, the fourth interpretation task is natural language processing, which is automatic computational processing of human language. Again, in daily life, you can see examples of this. For example, email spam filters. When the email sees certain language, it puts it into the junk folder. Or autocorrect when we are writing and your email autocorrects your language. Language translation is another example of natural language processing. The use of smart assistants like Siri or Alexa, and certainly search engine results, all of these rely on natural language processing. In terms of application to clinical care, the most obvious use is to use electronic health record data for clinical diagnoses. So in this scenario, what you do is if the algorithm can extract relevant or clinically relevant electronic medical record data, which can include your medical history from notes, the workup like radiology reports, ICD codes, CPT codes, medications, and even event information, and put that all together in order to interpret both the diagnosis of the patient or even to predict future events. And so this is a study where they used natural language processing for the diagnosis of pediatric diseases. What they did was they used an AI framework to extract clinically relevant information from electronic health records using natural language processing. And this involved over 100 million data points from over 1 million pediatric patients that were presenting to the center. They used this data to train and validate this AI framework. And when they then applied it to patients in order to make the diagnoses, they found that the model had a very high diagnostic accuracy across many organ systems, not limited to one organ, many organ systems, and was comparable to experienced pediatricians in diagnosing common childhood diseases like asthma or encephalitis, acute laryngitis, pneumonia, etc. But seeing as this is a genomics conference, I want to talk a little bit more about how AI applications have already made their way into genomics research as well as clinical genomics. And these are some of the areas where it has shown particular promise. Number one, variant calling, variant interpretation, protein structure prediction, and genotype-phenotype mapping. I'll give you an example for each of these. So variant calling example, an example for variant calling tools that involve AI is the Google Deep Variant, SNP and Indel Variant Caller. So this is a deep convolutional neural network that can call genetic variation by learning statistical relationships between the images of read pileups around the putative variant and the true genotype calls. So as you know, this is all about pattern recognition. If majority of the patients in a particular cohort have a certain base at a particular location, any variation in that base can then be recognized using AI. And in fact, it's now been found that deep variant can outperform some existing state-of-the-art tools and can also call variants across many sequencing technologies and platforms, which may make it more versatile than some of the more conventional models of variant calling. Another utility is in predicting deleterious variants. One example of that is the simple CAD score that almost everyone uses to predict the deleteriousness of mostly coding variants, but even for non-coding. What it is combined annotation dependent depletion approach. So what the CAD score does is that it takes input using machine learning from various sources like conservation databases, epigenetic modifications, functional prediction databases, as well as the context of the genetic profile, in order to aggregate that information, make a prediction of the likelihood of the variant being deleterious. This is now also, they have expanded this to also incorporate splice variants into the deleteriousness prediction. Splice AI is another example of using AI to predict splice junction. We know that splice variants disrupt the normal pattern of mRNA splicing, and as a result, they can affect gene expression, but they don't often lie only at the exon-intron boundaries. They often lie remote. They can be deep intronic, and for that, there aren't very clear ways of annotating them or predicting their function. So Splice AI, but whole genome sequencing provides you that information. So Splice AI is a deep residual neural network that predicts if a position in a pre-mRNA transcript is a splice donor, a splice acceptor, or neither. And it does that by recognizing sequence determinants over very large distances, even in deep intronic regions. And we now know that this network can predict splice junctions with 95% accuracy. And I will give you an example of how we have applied Splice AI in cardiomyopathy to detect cryptic or hidden splice variants. So this is work done by Gabriel Prasad and Robert Lusser from my group, where they took 257 cardiomyopathy probands who had whole genome sequencing performed. And from the ones who were gene elusive, we ran Splice AI and we found 13 putatively pathogenic cryptic splice altering variants in 5% of cases. And these were in genes like myosin binding protein C3, FLNC, TNNA3, vinculin, FOD3, and LDB3. These are three examples of three variants for which we actually had myocardium available. Now, all these three variants, 2 in FLNC and 1 in TNNA3, were all predicted to result in a frame shift and were associated with altered mRNA splicing. But what was very interesting was that we were able to show that they were associated with reduced gene expression in patient myocardium. So this is proteomic data from around 35 cardiomyopathy patients from whom we had myocardium available. And it shows that patients who had these two variants had much reduced expression of FLNC compared to other patients in the cohort who did not have these FLNC variants. And similarly, this is in green is a patient with the CTNNA3 cryptic splice variant, where you can see that the expression is much lower than that of most of the other patients who did not harbor these variants. So this suggests that Splice AI can be quite robust in its ability to predict functional splice variants. Another example is the use of AI for non-coding variant effect prediction. And one example is DeepSea. DeepSea is a deep learning framework that predicts genomic variant effects on regulatory features, not one, but many regulatory features like with single nucleotide sensitivity. So you can take a SNP and it can predict whether that variant will influence transcription factor binding, whether it is in a DNA's hypersensitive site or in the histone marks across multiple human cell types. So an example of how we applied it in cardiomyopathy is that, again, we took our cohort of cardiomyopathy whole genome patients, sequenced patients, and we identified rare variants that were in the promoter and enhancer regions of cardiomyopathy genes that overlapped ensemble regulatory features that are active in the human heart. And then we applied several prediction tools like RegulomDB, MotifBreakR, FathomMKL, and also DeepSea to predict if the variants that we identified in these promoter and enhancer regions were likely to have regulatory activity. And what we found was very exciting in that we found that 18% of patients harbored regulatory variants, which is a pretty significant number that had predictions of having regulatory activity. We had confidence in our findings because the variants that were predicted to be deleterious or predicted to have regulatory activity were enriched in the cases, as you can see in red, compared to the controls. And they were also replicated. These are the top genes enriched for regulatory variants, both in our discovery cohort, as well as in the Genomics England cohort. And finally, and most importantly, when we did a reporter assay called MPRA, or massively parallel reporter assay, we were able to show that 2/3 of the variants that were identified using these prediction tools had regulatory activity, suggesting that in the future, we may not need to do functional assays in every variant that we find, but we will be able to use these very sophisticated tools to make those predictions. And finally, in terms of protein structure prediction, this is one of the most exciting discoveries or most exciting developments in AI that has happened in the past year. This is Google's DeepMind program called AlphaFold, which is able, with high accuracy, to predict the 3D structure of a protein. Prediction of 3D structure has been a huge roadblock because it requires sophisticated tests like X-ray crystallography or cryo-electron microscopy, which are not high throughput, which are fairly intensive experimental methods to figure out the 3D structure. But what this program did is that it developed AlphaFold and it compared it to 100 other teams in a protein structure prediction challenge and found over time, in fact, that this AlphaFold can predict with close to 90% accuracy, it can predict the 3D structure of a protein, which is what predicts the protein function. And this has actually improved over time. And this is now going to, I think, is already changing how we do protein studies. And finally, very important, while the application to genomics is all well and true, a huge area is linking genomics to the phenotype and getting the phenotype or sort of understanding how phenotype evolves with time is one of the most difficult challenges when trying to do these kind of predictions. And so this is, again, where AI can play a huge role. And so I want to give you a couple of examples of that. So this is an example of a study that came out again a couple of years ago from VIII Children's Hospital in San Diego, where they used AI in order to diagnose genetic diseases in critically ill children or infants or newborns who were in the NICU or in the neonatal ICU. So what they did is first they built an automated pipeline to extract and analyze electronic health record data using, as we talked about, natural language processing. And they also used AI to detect genomic variants that were derived from whole genome sequencing done from dried blood spots in these patients. By using AI, they were able to then map the findings, clinical and genetic findings, to known genetic disorders and able to diagnose prospectively 3 of the 7 seriously ill patients, many of whom had. And this actually resulted in a change in management. So it was an actionable finding. It was very interesting that this kind of provisional diagnosis was made available in less than 24 hours in many of these patients, thereby reducing the journey of a very complex patient in terms of sort of what we call the diagnostic odyssey that can take years and that can take a lot of money and often still not yield results. Another example is using AI in order to do image and using image recognition in order to quantify cardiac phenotypes, especially when you already have your genetic data. And this is an example of a study that came out just very recently in JACC based on UK Biobank participants. In this study, they analyzed whole exome sequencing in 200,000 of 500,000 UK Biobank participants and found that these were supposedly healthy patients, but 2.9% harbored sarcomeric variants that are known to be associated with hypertrophic cardiomyopathy, and an additional 0.25% harbored non-sarcomeric HCM-associated variants that had been previously unrecognized. Because they had MRI data on around 21,000 of these patients with non-sarcomeric variants, they were able to do a genotype-phenotype analysis, and they used AI to actually quantify the thickness or the myocardial thickness from MRI without having to use individual core labs to do that. And then when they compared the presence of non-sarcomeric variants, they were able to show that non-sarcomeric HCM variants were associated with an increase in LV, maximum wall thickness, as well as development of heart failure over time. So you can see how this can reduce the time taken if you can use these approaches to interpret images or like MRI images or even echocardiography images and link it to other phenotypic and genetic data. I want to give you one example or maybe two examples of how we have been using AI or machine learning in order to identify or predict certain outcomes. So this is an example of a study we did in pediatric cancer survivors. This is Marie Shakes, who was a fellow with me and who is now adult congenital cardiologist in Montreal. So what we did is we had a multi-center study with close to 1,000 pediatric cancer survivors who had been exposed to anthracycline at some point in their past. We did exome sequencing in 184 cases. So these were patients who did not have very high dose anthracycline exposure, but still developed reduced ejection fraction. And 110 controls were patients who had high anthracycline dose exposure and yet did not develop reduced ejection fraction. And when we did a burden analysis, we identified certain genes that were enriched for rare and low frequency variants. We then combined this genetic data with clinical data of the patient, like age, gender, ethnicity, the dose of doxycycline that they were exposed to, whether they had chest radiation, what other medications that were used, and put this into a machine learning random forest model. And using this, we were able to develop 3 prediction models: a clinical only model that to predict anthracycline cardiotoxicity, a genetic only model, and a clinical plus genetic model. And what this shows is that in red is the clinical and genetic, this is just one example, a clinical and genetic model outperformed. This is the AUC for the clinical plus genetic model was 0.82 compared to 0.74 with the clinical only model. So using this machine learning approach, we were able to develop a model that was quite robust in terms of its ability to predict development of anthracycline cardiotoxicity. It had a sensitivity of 0.69, a specificity of 0.94, and misclassification rate of 0.14. And we were able to, of course, this was through a cross-validation. We are still working on doing an external validation of this model in a way that we can then apply the model to a patient before they are exposed to anthracycline to determine whether changes need to be made to their chemotherapy regimen ahead of time. And the last example I want to give is the use of machine learning to predict drug levels. We know that drug when it's administered can be absorbed in the intestines, metabolized in the liver, excreted in the kidneys, and all of any changes in the function or genetics of these or genetics can influence how a drug is metabolized. An example of a drug that has a very narrow therapeutic index used after organ transplant for preventing rejection is tacrolimus. If the levels are too high, there is a risk of side effects. Levels are too low, there's a risk of rejection. And it's been hard. It's always hard to get levels into a therapeutic range for this particular drug after transplant, even though it's so critical to maintain the integrity of the transplanted organ. And it can take sometimes 2 weeks or even longer to get this drug into stable levels. So what we did is we tried to develop a model that would be able to predict the level a patient would achieve depending upon the dose that they got. Usually we use standard starting doses. We identified certain clinical factors, again, in a multi-center Canadian study that involved over 700 participants. We identified several clinical factors that were predictors of tacrolimus levels after transplant, and that included not just the tacrolimus dose, but age, gender, whether or not they were on interacting drugs, and also the type of transplant. We also did a GWAS where we identified SNPs that were associated with how this drug is metabolized and therefore influences the drug levels. And we then combined these clinical genetic factors and put them into a model called a lasso model, which is again a machine learning model, which selected the 15 top variables that were associated with with the tacrolimus levels. And we used that to develop a prediction model. So what this shows is the performance of an integrated model, both clinical and genetic, versus a clinical only or genetic only model. And again, you can see in green that the combined model which had the clinical factors and the SNPs, had the lowest prediction error in terms of predicting what the tacrolimus levels would be after you first start the drug in a patient after transplant. In fact, this combined model explains 30% of the variation in tacrolimus levels compared to only 18% by the clinical model. And then when we looked at different organ types, we saw that this model performed best in heart transplant recipients, explaining over a third of the variation in the tacrolimus levels. So this is the kind of knowledge that you can now incorporate going forward, so that we have this information. We are doing SNPs, studying these SNPs routinely where we can before patients go for transplant. And our goal is to be able to incorporate this in order to guide that initial drug dosing to reduce the time it takes to get them into the therapeutic range. The advantage of the machine learning model, though, is not that it doesn't have to be a static model. A machine learning model, like we learn with experience, so can the machine. The computer can learn with experience as it is exposed to multiple patients and seeing how they perform and how the levels, whether their predictions were what one would have expected or whether there was a variation. They can keep adjusting and enhancing the model or the predictions to improve the accuracy. And that's more than the human mind can do. The machine or computer can have access to a lot more patients in real time than we do when we see a patient as one-offs. So naturally, there's no question that there is a huge room or huge scope for applying artificial intelligence in genomics and in healthcare, as well as pharmacogenomics, but there are certain challenges and limitations. One is about interpretability. And so one of the criticisms is that AI is a black box. You give the input, you get the output, but you don't know all these hidden layers as to how this output came about. And therefore, the examples that I have shown are where we have used factors that we found with evidence to be associated with the outcome or with the prediction before we put them into this machine learning model. But that is sort of not the way you will do it as you go forward. So that's very narrow AI. When you go wide, you almost have an agnostic approach. So we need a way to visualize how the predictions came about and do they make biological or clinical sense. So it's what you call the need for interpretable or explainable AI. The second issue is a machine bias. And this is often, not always, but often due to underrepresentation of subgroups. For example, deep Gestalt, which is the model that was used to predict a genetic disorder based on facial phenotype, was only 37% accurate in diagnosing Down syndrome in Black patients, compared to 80% accuracy in white patients, because most of the data fed to it were from white patients. Retraining the model using Black Down patients improves the prediction accuracy to 95%. A similar issue can arise with genetic risk prediction. If your model is developed based on genetic variants, say from a particular ethnicity, then the predictions may not be generalizable to other ethnicities unless you train the model on the genetic variation from other ethnicities. And then finally, there is the potential for discrimination. Given that there is a huge emphasis on pattern recognition and image recognition that AI can use, there is a risk that companies, insurance companies, employment agency can use that information in order to either diagnose for facial recognition, to diagnose conditions that you may not even be aware you have, or to predict certain behaviors and use that for discrimination. So there has to be some way of protecting privacy as this gets more and more widespread. So I'm going to summarize here to say that the most promising current AI applications that are relevant to genomics would be in genome variant calling, annotation, and impact prediction as far as clinical genomics goes, and certainly in the ability to extract deep phenotypic data to inform clinical diagnostics. The utility as a clinical decision support tool, though, still requires further study because while some have robust evidence to support the use, like some of the ones that are, as I said, FDA approved and the EMA approved, others have not. And we have to recognize that this is a niche, somewhat niche area where you require investment or hospitals in electronic health systems that are interoperable. As data grows, there's a need for more cloud computing as well as international data sharing frameworks. And in an era when we are living where we are concerned about climate impact, we do have to think about what the impact of the climate would be, but that's not something for discussion today. So I'm going to stop here, and I want to thank you for your attention. And once again, thank you for this opportunity for me to speak about a topic that is in its fledgling stages in the way we are trying to apply it in our cohorts. So thank you very much.
Thank you, Professor Mittal. That was a fascinating talk, and I think one of the best talks that I've heard on AI so far. So thank you very much. With that, I'd like to open the floor for questions. I'm not sure.
I think I see Eleanor.
Eleanor, yes.
Yeah.
So that's great. Thanks.
So a fantastic talk. I mean, you know, AI, machine learning, and automation are the key things that certainly I think those of us practicing are really trying to look towards, because pattern recognition in some of these relatively rare disorders is a real limitation actually to diagnoses. And also identifying different subtypes of HCM, for example. You know, the work is very much forward thinking, but actually pattern recognition to harness diagnostic capabilities and prognostic evaluation, I think, is really key. How do you think, how can we break down the barriers to prevent us from being able to achieve this in a pragmatic, practical perspective in clinical practice? Because it's very much in the research arena. And I mean, appreciating that we're international kind of allies, so to speak, it's very challenging within the NHS to see how we're going to be able to bring this in, because as you've mentioned, it's very resource heavy. At the moment, it's costly, but we absolutely need international data sharing frameworks for this, as you've mentioned, and particularly to try and reduce that machine bias that you've mentioned. So how can we pragmatically actually improve access for participation in research elements to try and refine things so that they actually are deliverable on a day-to-day basis? Because we need kind of massive collaboration from what I can glean. And, you know, but I think this is where we can achieve what may otherwise be quite non-sustainable services, particularly as diagnoses kind of exponentially increase and the burden on our services is increasing. I think this is an area where actually it could provide quite enormous benefit, even kind of ruling out people that don't have the inherited condition, for example, allowing us to spend more time to focus on those that do. So how do you think that we can try and break down the barriers that are going to prevent us from actually integrating this in day-to-day clinical practice without it just remaining in the research arena?
And that's a great question, Eleanor, and it's not something that can be answered really in a few minutes. I think that the challenge is not technological, the challenge is regulatory, and the issue is even within institutions, our own institution. It's almost easier to get your patient data into, say, Microsoft Azure, because it's been clear, you know, certified by the hospital. But if I want to put, say, even research data into a Google Cloud, I'm not permitted because they've not been certified by the institution. So institutions legitimately want to make sure data is secure and protected, but that creates a huge bottleneck in our ability to integrate, even within our own institution, the clinical data with the genetic data, which is being generated at the research level, and then let alone trying to share it across institutions and across countries, because each country has its own regulatory framework. So in short, that is the problem, which I think technology is not the problem. Yeah, you have to invest in storage and you need data scientists and whatnot. It's that how do you cross that burden, or how do you, right? And I don't have the answer to that because this is where I think advocacy or even at the patient level might be important, where we've asked patients and they say, so long as the data is secure, we have no problem if it helps with diagnoses to have the data sharing occur, but it's rigid frameworks that have been put into place that is sort of interfering.
I mean, I think I'd agree. I mean, it almost does require the patient portal, the patient kind of element to actually stand up to say, as long as the data is used responsibly, to consent at the front door, almost that whole early concept of it, I think would hopefully help overcome some of the barriers. But it's a complicated complicated infrastructure, which we really do need to resolve one way or another. We need to kind of figure a strategy forward. So I found that really insightful. So thank you very much. Thank you.
Thank you. I think we've got another question. Federica Montanaro.
Hello, Sima. Can you hear me?
Yes.
Thank you very much for this talk. It was really very, very interesting. I enjoyed it a lot. And when you were talking about the protein folding algorithms, I know for a fact, and we've been trying to play around with some of those, that the next stage is to look at protein-protein interactions. So try to predict how two folded proteins would actually come together. It's a real challenge. I know it's working relatively well with prokaryotic proteins, and where people are moving on to try and test it on eukaryotic proteins. And it's something that is quite important, for proteins like dystrophin and a lot of these proteins involved in cardiomyopathies that interact with each other. So I'm really glad that you brought this up. I have a question that is sort of related to what Eleanor was also saying, that beyond bringing this to the clinic, is there an ethical way of bringing this into our biobanks? When we're making patient database banks and collecting tissues for genetic analysis and so forth, it almost seems like you're saying it would be really useful to get a picture of their face, of their ear perhaps, and all of these other features, but it definitely poses big issues with identification of the person. So do you see a way to go beyond that or overcome that issue?
I mean, there's no way around. You have to get patient consent, and with certainly the electronic health systems, many patients, even for the clinical health records, are happy to have their child's image be part of that, and others are not. And so patients are being given more and more, I think, space within the electronic health records. For example, Epic would be My Epic, where they can not just access things, but they can communicate. So I think like what Eleanor said as well, at some level, the patient portals may override these kind of hospital-driven portals in order for them to make their own decisions about what they want to put into these kind of systems. It's a shame that if they don't interact with hospital portals, then that's an opportunity lost. We're certainly trying. We have, as part of a Ted Rogers Center for Heart Research, in the next 5 to 10 years, our goal really is to find ways to do this kind of integration of these various data sources and apply AI, at least within the few institutions that are part of this one center. And if we can do it there, then maybe we can, find other ways of accessing it. But there is no easy solution right now. It's difficult.
It just seems to be like a bit of a blind spot at the moment. We're just really not collecting that data, or thinking even of collecting the data when we're collecting tissues or samples.
Correct. I mean, just one thing I would add is that so there are certainly there's some very cancer biobanking software or platforms where they do capture not the faces, but they capture tumor images, histopath images, all those along with everything else. So they have that in place. I think for not every field has been able to integrate that as well.
Brilliant. Thank you very much. And any other questions on the floor?
Can I just make one quick point? Because I think, again, for example, interpretation of ECGs, where within the cardiology clinic, as you become more and more experienced over time, you kind of detect the subtleties that perhaps the junior doctors or allied health professionals working in the same sort of fields just simply can't, or it takes years of experience. That's another area where, if you had some kind of automated auto flag to say, oh, this looks like HCM of whichever format, or this could be a restrictive, or this, actually having that pattern recognition to at least support clinical services, I think could be enormously beneficial.
And I think that would be huge for sort of in some way it can help democratize care, because in remote areas where you don't need an echocardiographer interpreting it, right? You have a technologist who sends the images centrally and gets flagged, or even I think there is actually, even though it is somewhat elite medicine at this time, it can be democratized much better as time goes on.
Yeah, and enable the equity to access that otherwise is very much depending on your local centre or your regional centre that may have the expertise.
Thank
Yes,
you.
no, I think I take your point. I think that bit is already being doing in acute myocardial infarction, where you've got the AI technique. So I think there's scope for further. And perhaps I think the greatest bit that comes away is that maybe these techniques can help us control our overburdened clinic follow-ups because of the gene elusive, where you sort of then cascade screening of family members. So I see a huge potential for that field. But no, thank you very much, Professor Mitchell, for a beautiful talk. And if there are no other questions, then I'd like to thank you on behalf of the organizers. And again, thank you very much for a very fascinating talk. Over to you, Devendra, for...
Thank you, Neha. And again, many thanks to Seema. You finally showed up and managed to answer key questions. They're very exciting. I mean, I had no idea. I mean, I know my children will just make fun of if I will be speaking to Alexa, and I have no idea what does it mean, you know. I know I have some understanding. So we move on to the next and the final session of this conference, the prestigious William Harvey Oration. This is the second one in line. We set up this oration at the last conference held in New York. And I must admit the preference of William Harvey being my own personal bias right from as a young boy and also a young medical student. I was always fascinated by William Harvey's experiments on animals and also to himself. And it just happened that for the last 3 years, I'm associated with the William Harvey Research Institute. So no wonder I preferred this title. And the first oration was given by Professor Bill McKenna. Most of you know that as a clinical cardiologist, he spent his whole life pursuing the clinical applications in cardiology in Britain. People call him a father of cardiovascular genetics, and I was entirely agree. So he was the first speaker. Second speaker today, we have got Professor Dan Roden, one of the eminent clinical scientists. And I will leave it to now Professor Azavelde to really introduce him. Thank you.
Thank you, Devendra. And it's a great pleasure and honor to introduce Professor Dan Roden. You then started in Vanderbilt in 1978, and he's a professor at the same institute since 1998 in the Department of Medicine and Pharmacology. In 2004, Vanderbilt already started the biobank and then was the principal investigator of it. And over the years and the years thereafter, and that is also the topic of today, is how to merge the immense amount of data in the electronic medical records with the genomic data. That has been his task in the last many years already. He has published quite a lot of exciting papers on this. And it's also the topic of today. So then it's a great pleasure that we give you the floor and welcome you to this meeting. You can take control of the screen. We do see your screen, but we don't hear you yet.
I think he's muted.
You have to unmute.
Unmute.
Yes.
Now, do you see my screen?
Yes.
Yes. No, not now. We see you, but we hear you, but we don't see the screen yet.
Screen
Okay.
share.
I will share. Now, do you see my screen?
Yeah, that's it. We hear you and we see the screen.
Perfect.
Please go ahead.
So what I was saying was that I look forward to sitting in the audience for the third or fourth William Harvey Oration. I really, like all the rest of you, I'm getting better at Zoom. I'm obviously not perfect, and I look forward to getting rid of Zoom and resuming a sort of person-to-person interaction. I appreciate the opportunity. I'll have a little to say about William Harvey. I'll have a lot to say about history, and then I'll have a little bit to say about where we are now and where we want to go. And I didn't realize that Dr. McKenna was the first of the William Harvey speakers. I've known Dr. McKenna since we both started medical school in 1970 at the same institution at McGill. So 2 McGill graduates in a row. How strange. These are my disclosures. I have no industry connections, so those are things you can read quickly. A little bit about William Harvey. There's a quote from William Harvey that I've used over and over again, which I will show you now, and I'll read it to you. Nature is nowhere accustomed more openly to display her secret mysteries than in cases where she shows tracings of her workings apart from the beaten paths. Nor is there any better way to advance the proper practice of medicine than to give our minds to the discovery of the usual law of nature by careful investigation of cases of rare forms of disease. So I think this epitomizes one of the driving forces of genomic medicine, and that is the idea that by discovering the basis of rare diseases, we discover the basis of common physiology and common pathology. And everybody who has spoken about collagen or cardiomyopathies or channelopathies understands the implications of their work for more general pathology. So a couple of slides about history. William Harvey in the 1600s. My parents are Czech, and this is the Czech monk Gregor Mendel in the 1850s. Archibald Garrett was Regius Professor of Medicine at Oxford, and arguably the inventor of pharmacogenetics. He also coined the term, he studied inherited heart disease, inherited diseases of metabolism. And then, of course, 1963, Watson and Crick and the largely unrecognized contribution of Rosalind Franklin to develop the double helix structure that forms the basis of what we're talking about today. This is a headline from our local newspaper from many years ago now. We saw this family after the 13-year-old girl died playing basketball. This is the ECG of her 9-year-old sister with manifest QT prolongation. This was so long ago, there was no commercial genetic testing. The genes had just been described. We identified the mutation in this young woman and then looked at her family. Interestingly, it was her mother who was the mutation carrier with a normal QT interval. And her grandfather was a mutation carrier with an entirely normal QT interval, died of a stroke in his late 70s. And I followed this family long enough now that there is a fourth generation even. Another view of personalizing medicine, or why we need to know something about an individual's genetics, is this anecdote: a 57-year-old woman with type 2 diabetes, family history of heart disease, hypercholesterolemia, admitted with chest pain, gets a stent, gets put on clopidogrel, Plavix, and over the course of the next year has multiple readmissions for in-stent thrombosis, more Plavix, more in-stent thrombosis, finally gets tested, turns out to be a CYP2C19 STAR2 homozygote, so giving her clopidogrel is like giving her placebo, and she has switched to prasugrel. So this is what I call the fundamental paradox and opportunity in precision medicine, and that is that if we're going to take people and not treat them as average, we have to have a large denominator from which to draw individual subsets that we can then study and say, this person is different enough from average that they should be treated differently. And those small groups of people can be pharmacogenetic outliers. They can be people with unrecognized Mendelian diseases. I'm fond of saying, when I look at our electronic health record, that there is no patient who takes only one medicine and there's no patient who has only one disease. That's a generalization, of course, but it is true to a large extent in a tertiary care hospital. And then, of course, if we have large data sets, we can then start to ask questions about subsets. So biologically or therapeutically important subsets of diabetes, cancer, heart failure, what have you, to develop personalized therapies and new drug targets and preventive therapies. So as Arthur mentioned, we started over 15 years ago to plan a biobank that is electronic health record based. So the entire phenotype resides in a de-identified image of the electronic health record. That's about 3 million records that are available for research independent of genomics. And then there's a subset that have DNA, around 250,000 currently. And we are one of many, many resources now that have large collections of phenotypes and genotypes, mainly phenotypes, mainly genotypes. DOMAD, of course, has very few phenotypes, but the Million Veterans Program, all of us, I'll say something more about that at the end. And the eMERGE networks, the Electronic Medical Records Network, I'll say something more about that. And of course, it's not confined only to the United States. This is a worldwide effort. The Estonians were some of the first in there with their biobank. And of course, UK Biobank has turned out to be a fantastic resource for many, many different types of studies, including the AI studies that you just heard about. And there are many disease consortia around the world that have collected large amounts of phenotypic and genotypic data. So how did we get to genomic medicine? I think that there are three parts of this. One is discovery, second is cataloging, and a third is implementation. I'll say a little bit about discovery and cataloging. Up until 2003, the major advances were the ability to sequence DNA. This is a Sanger sequence. The invention of the polymerase chain reaction. Many, many studies in pharmacogenetics defining families, individuals and families with unusual drug responses because of aberrant metabolism. And then the key development in my mind was the development of the personal computer. This is a picture of an old IBM XT, one of my first personal computer, because it was the personal computer that enabled the electronic health record. And it was the personal computer that enabled the computing power behind the personal computers that enabled the Human Genome Project and sequencing of the initial human genome, and now literally hundreds of thousands of genomes afterwards. So those advances are the fundamental basis of genomic medicine. The first GWASs were for age-related macular degeneration, but I think the real sort of conceptual breakthrough occurred with the Wellcome Trust Case Control Consortium, published in Nature in 2007. These are GWASs for 7 common diseases. And what was interesting is that everybody was either a case or a control. So that the idea of using genetic data over and over again in multiple kinds of studies was really pioneered by this sort of concept. And you'll notice that some of these GWASs, like for hypertension and bipolar disorder, don't yield anything, and others yielded replication of known signals. So that formed the basis of the creation of biobanks, the creation of the eMERGE network, creation of other networks that we have been part of, and the development of electronic health record-based genetic studies, which I'd love to talk to you about, but I can't. And then the business of cataloging, the NCBI started to catalog SNPs in the mid-2000 noughts. In 2006, the 10 millionth SNP was reported. And of course, the Nomad resource now collects, in its next incarnation, will have over 500,000 exomes and over 200,000 whole genomes from across the world. So the idea is that discovery feeds implementation, and then implementation then feeds back to discovery, as the AI talk that we heard just now from Dr. Mittal showed really, really nicely. So I want to talk a little bit about discovery and then talk about implementation. So one of the ways in which large data sets have enabled discovery is that you set very, very clever people to work in very large data sets, and they come up with really interesting and novel ways of analyzing data. GWAS, of course, is one example of that. And here is another. This is why we created our biobank. We created our biobank with the idea that we would identify a human trait, use genomic information, and then find the associated loci, genes, and specific variants that modulate susceptibility to that trait. But when I was sitting in a room in 2009, and someone said, well, we have enough data in our electronic health record across many diagnoses, and we're starting to collect genotypic information, that we can turn this experiment on its head. So we can ask, with what human phenotype is a genetic variant associated, using this kind of approach. So the word PheWAS, phenome-wide association study, was coined in that meeting room in 2009, and a couple of early studies validated the idea, and then a large study involving the eMERGE network. And when I say large, in 2013, large was 13,000 subjects. This appeared in Nature Biotechnology. We're very proud of that. This is the eMERGE network. The lead author was a guy named Josh Denny. We were happy to have a paper in a high impact Nature journal. We were even happier to have it in a high impact New York Times article. So this is Josh, and I'll come back to Josh and what he's been doing with his life lately. So there are many, many ways in which PheWAS has been used to validate the results of GWAS. Here's an example where PheWAS was used to validate drug targets and to identify new drug targets. The idea here is that you identify genes that encode known drug targets. You then ask the question, do variants in those known drug targets modulate the disease for which the drug is being used? And those variants that track with the disease are then thought to be functional in this sense. Then you ask the question, what other diseases associate with those variants? So for example, the known phenotype of the first gene is inflammatory bowel disease, but the other phenotype that tracks with it is hypothyroidism. With a modest odds ratio, I would say that. The ones in bold are interesting because those are adverse. This is a prediction of an asthma adverse drug reaction to a type 1 diabetes targeted drug. Notice that the odds ratios are modest, and notice also that the numbers needed to generate these signals are huge. But once you have the signal, then you can start to hone in on whether this is a legitimate second drug target or not. I have lots and lots of other PheWAS examples, which I won't show you. We've also harnessed the electronic health record to find cases because we're very interested in adverse drug reactions, and in particular, rare adverse drug reactions. So here's an example of a patient with drug-induced torsade. This is one of my personal obsessions. We have a system set up in our hospital where when the word torsade is typed into an electronic health record, as soon as the save button is pushed, I get electronic notification, by an email that says this medical record number has the word torsade in it. Now, whether it's a false positive or negative, what it is, we have to then go back and look at. And what we're using this for, among others, is to take a large population of patients, look at patients who've had torsade and who haven't, go back to them, get permission to generate induced pluripotent stem cells, derive cardiomyocytes, and then study those cardiomyocytes with the idea of creating predictors of good response and not good response. And we have dozens and dozens of lines from various patients, and someday I'll be able to talk about what those lines have showed us. They're showing us some interesting things, not the topic for today's conversation. So I showed you this slide before, but we realized also that we didn't have to interrogate single variants. We could interrogate sets of variants. So this is an idea that my colleague Nancy Cox, who is the director of the Vanderbilt Genetics Institute, came up with. So Nancy, when she came to Vanderbilt 6 years ago, was one of the PIs of a resource called GTEx. GTEx takes tissue samples from recently deceased healthy individuals and does RNA sequencing and whole genome sequencing, RNA sequencing across multiple tissues and whole genome sequencing. So they have this very large resource, and her idea was to create genetic predictors of gene expression. So the question is, can you predict variability in expression of your favorite gene and your favorite tissue? And then you ask the question, does the predictor that I have predict any phenotype using the PheWAS approach across our biobank BioView? So here's an example of predicted reduced expression of a gene called GRIC5. And when you look at these lists out of Excel, They always look like the telephone book, but this one is interesting because there are many, many eye phenotypes. And that's unusual. And they're diverse eye phenotypes. They're not one kind of eye disease or not. Working with the zebrafish people at Vanderbilt, Nancy and colleagues showed that if you inject anti-GRIC5, if you knock down GRIC5 in zebrafish embryos, you end up with fish that have either one eye or one big eye and one not so developed eye. She has gone on. This was published in the American Journal of Human Genetics a couple of years ago. The number of phenotypes that you should expect is in this distribution here. So the number of eye phenotypes of GRIC5 is much higher than you would expect. And then when you look at reduced expression of GRIC5, and this is this group of people here, there's a vast overexpression of coexisting vascular disorders. And it turns out that this GRIC5 decreased expression with eye development is a vascular disease. So this is the idea of using electronic health records to go back to basic biology and then come back to a whole organ and whole people. So I have dozens of examples of how the electronic health record has been used for discovery, but I want to move on to implementation. So the classic way of implementing is to understand what the gene is in a family and then counsel the family through cascade screening and other mechanisms. The advent of whole genome sequencing has raised the challenge of how to annotate a whole genome sequence for an individual. I don't know how many of you have had your whole genomes sequenced. I have, and getting it annotated is a real challenge. This is the first whole genome that was ever sequenced, and it took a team of about 50 investigators 2 years to annotate the whole genome, annotate the common variants, annotate the pharmacogenetic variants, and annotate the rare variants that might be associated with the disease. Those are automated pipelines now, but it's still a major challenge. Using whole genome sequence obviously has been interesting in diagnosing undiagnosed diseases, and the Undiagnosed Disease Network in the United States has been a pioneer in that. And the idea of using rapid DNA sequencing in critically ill neonates was already referred to in the previous talk. Genomic medicine and understanding the underpinnings of genomic disease has led to new drug therapies. This is an example of PET scans. These are now 10 years old. PET scans before and after vemurafenib in a patient with the V600E BRAF-driven melanoma. You can see multiple metastases that melt away after 3 weeks of therapy with vemurafenib. And as many of you know, there's escape from this, and the mechanisms of escape have led to better therapies for melanoma in general. And of course, in the cardiovascular space, we have PCSK9 inhibitors as a direct result of our understanding of the genetics of hypercholesterolemia and understanding that patients with variants in PCSK9 that are loss of function actually have low LDL cholesterols. And then of course, those of us interested in implementation that are not in England are intensely jealous of the major investment that the UK and England have made in Genomics England in all of these areas and then some to help us understand how to implement. So this is a cartoon that I'm fond of showing, and I've shown for a long time, from the New Yorker in 2000 when the first draft human genome sequence was published. It's a lady handing her sequence to a befuddled pharmacist, and she says, here's my sequence and do something good with it. I think this is happening. It's not happening with a piece of paper. It does emphasize the idea that this is a team sport. It's not just physicians, but it's other healthcare providers, counselors, pharmacists, nurses, other kinds of experts, and it involves the patients. So this patient is asking, I have a high phenotype risk score for Marfan syndrome. Should I worry? So I want to tell you a little bit about what a phenotype risk score is. The phenotype risk score is a brainchild of a very talented data analyst, now faculty member at Vanderbilt's Department of Biomedical Informatics, Lisa Bastarash. So Lisa had this idea that you could identify patients who had undiagnosed genetic diseases by looking at their combinations of phenotypes. So here's a Marfan example. We have examples across many diseases now where the top patient looks like they have a number of features that are seen in Marfan syndrome. The second patient, maybe not so much, and the third patient has no Marfan syndrome. So you assign each of these symptoms a score, and the score is weighted based on how common they are in Marfan syndrome versus how common they are in the general population. And then you add up the scores. So for each of the phenotype terms, you give it a 1 if it's present, and a 0 if it's absent, and then you multiply it by the weights, and these are the weights. So this patient, the top patient, has a very high score. The middle patient has a medium score. This patient has a score of 0. And then we go back to a set of data where we have a group of patients who we know have Marfan syndrome, or we know do not have Marfan syndrome, and the normalized phenotype risk scores separate these two really, really nicely. And we did this for cystic fibrosis and Leaf-Raumini syndrome and achondroplasia, and the p-values are always less than 10 to the minus 100. So this is a very robust way of looking at patients. I have a number of ways in which this might be applied that I don't have time to talk about. I wish I did. One of the ways in which we're thinking about applying it, or which we're trying to think about how to apply it, is to obviously deploy it across the electronic record and see if there are patients with high phenotype risk scores who don't yet carry a diagnosis. And we're working on that part of the story. I want to talk to you a little bit about a different application. So this application starts in a different way. This is a project called the eMERGE-seq project, which we ran in the eMERGE network in the last cycle between 2015 and 2020. We sequenced 109 Mendelian disease genes in 25,000 patients, mainly middle-aged subjects with no particular diseases, although the entry criteria were a little mushy. There were some children, there were some people with a strong suspicion of genetic disease, so it's a little bit heterogeneous. But the idea is that we sequence these genes, and there was a 6% incidence of likely pathogenic or pathogenic variants, including mostly in cancer susceptibility genes or in cardiac genes. We separate out familial hypercholesterolemia. So when you add up the cardiac genes, they're about the same as the cancer genes, and lots of other little genes here. And here is the problem that I want to talk about for the next 5 or 10 minutes. And it's shown on this slide. In the 34 cardiovascular genes that we interrogated, there were 5,877 variants. And 5,460 of those were variants of uncertain significance. 133 were designated pathogenic, and 284 designated benign. So we have a huge problem if we're going to implement genomic medicine, because we have lots of sequence data, but no way of understanding the function of these variants of uncertain significance. And those of us who get reports like this obviously sort of know the problem, that you don't know which of these two genes is responsible for the patient's phenotype, if either. So the problem is that in NOMAD, for example, there are, at the time this particular publication came out, there were almost 5 million missense variants. 100,000 of those have an assertion in ClinVar, the data set of annotated genetic variants. And of those assertions, most are VUS. So the vast majority of missense variants that you ever see have no assertion whatsoever with regard to pathogenicity. So the approaches to solving this problem is in silico, including AI, that, as you've heard, an in vitro study, traditionally one variant at a time, or many variants at a time, or maybe even all possible variants. And I'll show you how we're thinking about that. And then in population or family studies, do variant carriers have a phenotype? So I want to come back to the idea of phenotype risk scores in Marfan syndrome for a second. One of the other genes that we studied was FBN1 in the eMERGE-seq project. And what Lisa did was she went back into the data set and found, when we looked at, this is actually 15,000, so an early look at the Marfan syndrome phenotype risk scores in this data set. when we looked at known pathogenic variants, they had high phenotype risk scores for Marfan syndrome. When we looked at benign variants, some of which are synonymous, as you can see, they had very, very low phenotype risk scores. So the phenotype risk score for Marfan syndrome works in BioView, and it worked in the electronic health record system. There were also 82 FBN VUSs, and here too, that have very high phenotype risk scores. So I would assert to you that just the electronic medical record is able to move at least these two variants toward, if not to, pathogenic. Another way in which we're approaching this problem is through what we call high throughput automated patch clamping. I would call it medium throughput now, but this is a study that Andrew Glazer, who's now a young faculty member in our group at Vanderbilt, did when he was a senior fellow. He studied 82 sodium channel variants. The type is so small you can't see what any of them are, so you have to go to the paper in 2020. 10 of those were selected to be benign, and this is peak sodium current compared to wild type. Wild type is here, normalized to 100%. And these are values. In automated patch clamping, you can do multiple replicates. So each of these is at least 6 replicates of cells studied on this automated patch clamp platform. And each of the benign variants has a peak sodium current that is roughly the same as wild type. So those are benign. And then here are some VUSs or some variants that have been seen in Brugada syndrome, a loss of function disease in the sodium channel. And some of them behave like wild type. Some of them are total loss of function, and some of them are intermediate. And based on these data and ACMG criteria, Andrew was able to reclassify 61 VUSs, 35 of them as pathogenic, 14 of them benign, and he had to leave 12 of them as variants of uncertain significance. And one of the interesting things is that when you go back to look at the pathogenic variants and then map them onto the structures, so again, structure is a key part of all this. Here are 2 examples that I think are, tell the story in pictures much better than I can in words. The one on the glutamate at position 901 is near the pore, the permeation pore of the sodium channels. The wild type channel has a pore through which sodium ions go. And when that is mutated to a lysine, the pore is occluded. So this is a loss of function variant. This is another variant that I think is even more interesting. The cysteine at position 335 in the structure forms a disulfide bond with a cysteine that's quite far away at position 280. And when you mutate that cysteine to an arginine, you lose that disulfide bond. The structure is destabilized, and that's also a loss of function variant. So using structure, using function together, you can reclassify variants. And Andrew and a senior cardiology fellow, Giovanni D'Augusto, have gone into the 25,000 patients who have had sequencing and looked at the arrhythmia genes specifically. So this is actually a subset of about 21,000. So when you look at the ones who don't have any variant at all, that's 19,000, almost 20,000 patients, and then ask what phenotypes do you see in the electronic records? You see extreme phenotypes, moderate arrhythmia phenotypes. This is advanced AV block, sick sinus syndrome, implanted devices, atrial fibrillation, flutter, PVCs. These abbreviations are familiar to all of you. So when you look at the pathogenic or likely pathogenic variants across this set of genes, you see significant enrichment at the gene level for some of the genes, for KCNH2, KCNQ1, LMNA. It's not statistically significant for SCN5A. And then when you look at the VUSs, in general, the VUSs have the same kinds of phenotypes as you in the electronic record as you see in patients with no variants. But then we go back and look at the VUSs not by gene, but by variant, and looked at each VUS and asked the question, is there anything in that VUS? Is there anything in the electronic record for that particular VUS? Now, the numbers are very small, usually 1 patient, occasionally more than 1 patient. And then what you do is for these candidates, you do high throughput automated patch clamping. And that's what they have done. And they were able to reclassify a couple to benign and a bunch to pathogenic based on the electronic health record plus the in vitro phenotyping. So the other approach that we and many others have been thinking about is how to study all possible missense variants in a particular coding region. So here is one idea. We've studied KCNE1. We've done this with a couple of genes now, where you create a plasmid, you do bulk mutagenesis, creating every single possible mutation. You recombine into cells that are specially engineered to accommodate exactly one insert per cell. And then you do something. In this case, we ask the question, which ones appear on the cell surface? And we sort by cell surface expression. In this particular experiment, this is the graduate student, Aisha Muhammad, who's done this experiment. And you ask the question, when you sequence these pools, which of these pools correspond to which of these variants that do or do not traffic? And it is possible, as you can see in this map, to create a map for nearly all variants. The red means loss of function, loss of cell surface expression. The blue means normal or greater than normal expression. And the gray is that we didn't see those particular variants. So this is work in progress. What's interesting is that the top row is nonsense variants. These are stop codons at each position. So when you lose KCNE1 by having a stop codon in the transmembrane segment at position 56, you don't get cell surface expression of the relevant potassium channel. When you go to position 59, you do get normal cell surface expression. So what that tells us is that the C-terminus of this protein, this part, is not required for cell surface expression of the potassium channel complex. I should say that the cells that we put these into were engineered to have the protein partner for KCNE1, KCNQ1. So we're looking at the complex here. So we think we can get insights into biology. We think we can get insights into structure by doing bulk variant effect maps. So another area in which obviously the woman would like her sequence analyzed is in pharmacogenetics. We've had a project at Vanderbilt for the last 10 years where we embed pharmacogenetic information in patients' electronic record. It's not a very elegant kind of interface shown here, but each one of these has links, and they're linked more importantly to real-time decision support. So if a person who has a loss of function variant at CYP2C19 is prescribed clopidogrel, the system will respond by saying, this person has variant genetics, do you really want to do this or not? When we looked in the first 13,000 or so patients in this project, what we found was that there was a small percentage, 2.7%, who were homozygous for loss of function variants, like the patient I showed you at the very beginning. And those patients are at high risk. There's about 20% that are heterozygous for loss of function, and those are people at moderate risk. And most people have no variants. So one idea is, why are we bothering to do this when only a small proportion of patients are really the ones at high risk? And I have three takeaway messages from our studies in PREDICT. I have many takeaway messages, three major ones. One is that if you look in NOMAD, there are literally hundreds of missense variants in CYP2C19, most of which don't carry function. So we think this idea of generating variant effect maps for CYP2C19 will turn out to be very important, looking at function. When we looked at only 5 drug gene pairs in our first 10,000 people, almost everybody has a genetic variant in one of those, in one of the genes that drive variability in response to that particular drug. You don't know what variant you have, and you don't know whether you're going to be exposed to that drug. But our number was 91%. Other people quote numbers of 99%. So most people have a genetic variant in some gene that is important for drug response. And then we looked at factors mediating whether physicians or healthcare providers pay attention, and they do. If somebody is a homozygote, they pay more attention than if they're a heterozygote. And there's tremendous inter-individual variability in the extent to which providers pay attention. Now, that was in 2016, and we'd like to think that with more and more emphasis on genomic medicine, then that variability at least will go away in part. So another application is this idea of polygenic risk scores. My doctor just prescribed sotalol, and it says here I have a high polygenic risk score for QT prolongation and Torsad with sotalol. Should I worry? And the answer is yes, you should worry. So polygenic risk scores, in brief, for those of you who have never heard of these things before, and I'm sure that everybody has, you take a genome-wide association study, you generate a polygenic risk score that can be anywhere from a couple of dozen to millions and millions of SNPs. And you say, you get a score of 2 if you have 2 risk alleles, 1 if you have 1 risk allele, 0 if you have no risk alleles. There's a weighting factor that is basically the betas that come out of the GWAS. And then you construct a polygenic risk score. These are data from, this is a cartoon from the cancer literature, in fact, but it shows very nicely the difference between a population control and cases of whatever disease you want to study. And people with the idea of a polygenic risk score is that people with the disease have a much higher burden of high risk alleles than the population in general. And you can see the variance go from n equals 1 to n equals 6 million or n equals a couple of hundred or whatever you want. And then you construct polygenic risk scores and ask the question, what happens to disease incidence? And I think this is a really lovely way of representing this. I'll tell you what this disease is in a second, but it doesn't matter. Here is a group of people who have low polygenic risk scores, and they get the disease by the time they're 80. Here's a group of people who have high polygenic risk scores. They have a 2 or 3-fold higher increase in risk. So this is what the polygenic risk score is telling you, that over time, the risk is 2 to 3-fold. It's not 100-fold. It's not 200-fold. It's 2 to 3-fold. And is that important or not? We really don't know. This example happens to be ovarian cancer, but it could be coronary artery disease. It could be whatever you like, because anything that has a GWAS can have a polygenic risk score. We looked at polygenic risk scores for predicting Torsad, and when we did a GWAS for Torsad, we found nothing, and there was nothing that was useful out of that. But then we and others looked at a polygenic risk score derived from baseline QT intervals. So the genetic architecture of the QT interval at baseline as a predictor of drug-induced Torsad, and there's a very nice separation between cases and controls, and with a p-value that's very, very respectable for this. All you need is 0.05 for these two distributions to be different. This was done in support of supported by a Leduc network in cardiovascular medicine, and Arthur Wilder was part of that Leduc. And polygenic risk scores, not only to predict drug-induced long QT, but variable penetrance in the congenital long QT, and as in the example I showed you before. And then Connie Bazina has done lovely work on genotype negative long QT syndrome that was published last year. And of course, the same logic applies to predicting whatever disease you want. And these things are being rolled out for all these diseases and then some. So in the current cycle of eMERGE 4, we are looking at polygenic risk scores. So we're trying, the idea in eMERGE 4 is to use whatever tools we have to identify people who are at high risk for a common disease. And how do we assess risk? We assess it using clinical risk factors where those are known. We assess it using family history where that is known, and genetic risk using either rare variants or polygenic risk scores. And the focus here is going to be on polygenic risk scores. We're going to study 10 to 20 common diseases. We think we have the final list, but it's not public yet. They're going to be across the spectrum of ages, and that's going to be complicated. And then the interventions and follow-up will depend on the diseases. But the idea is every patient will get a report. And the report will say, you are at very high risk for a disease, or you are a participant in this study. You are not at very, very high risk. That doesn't mean you're not at risk, but it just means you're not at very, very high risk. And then we're going to identify the highest risk group of people and recommend interventions and track outcomes. It's easy to say that. I can tell you we've spent the last year and a half trying to design this study, and the devil is in the details, but we think we're almost there. So, whoa, what happened there? So I've talked to you about health records and genomics. But there are many other tools that we would use and many others would use to define individualized health. Things like images, we have in BioView, we have a subset of data called ImageView, other omics, transcriptomics, metabolomics. There's a huge interest in digital health technologies. We're using induced pluripotent stem cells. I think that's part of personalized medicine, discovery, and eventually even perhaps therapy, but that's down the road a little bit. And then, of course, there are other determinants of health that are hugely important and that we don't capture in the genome. People say that, you know, for some diseases, it's not the genetic code, but the zip code that is much more important for disease susceptibility. Things like how close to a grocery store do you live, or what your socioeconomic status is. So the challenge is to integrate all those multiple sets in a way that will deliver, identify people at high risk and will deliver individualized therapies. And that's the challenge that we're facing in the All of Us initiative. So the All of Us initiative, which I'll tell you a little bit more about in a second, has a data and research center that is centered at Vanderbilt. And I'll talk a little bit about what we do in that center. The Data and Research Center was founded by Josh Denny, whose picture I had shown you before. Josh has moved on to be the Chief Executive Officer of the All of Us initiative in Washington. So he's in charge of the whole project now. So I have been designated as the leader of the Data and Research Center, and my co-leader is Paul Harris. Paul is a very, very talented bioinformatics expert, who many of you may know because he is the inventor of the REDCap resource that is used in many, many environments to capture research data. REDCap is Paul's brainchild, and the Data and Research Center is in large measure what he and Josh have built. So all of us, we are building a research program to engage 1 million participants. Unlike many other resources, this is built from the ground up with the idea of returning as much data as we can to the participants as we do it. We've recruited to date 405,000. Obviously had a big bump in the last 18 months, but we're starting to recruit again. We have about 250,000 of those have electronic health records so far, and we have biosamples on about 310,000. The resource is open for use. There are almost 1,000 investigators. This slide is out of date because we're over 1,000 now. Around 80% of these participants are underrepresented in biomedical research at some level, either because of ancestry, socioeconomic status, access to the internet, LGBT status. The Data and Research Center aims are to get the data, secure the data, organize the data, and then make it useful to the participants and make it useful to the research community. There's a public tier that is available now. Anybody can go to the website and see what there is. There's a registered tier, which is actually pretty easy to use. It takes about 1.5 hours to register for. Currently confined to US investigators. We're working very, very hard to figure out ways of making it available to anybody nationally and internationally. There is a controlled tier, which is going to be available this fall there won't be any personally identified information, PII, in there. There will be 100,000 whole genomes that we plan to release in this coming winter. I know the target date, but I don't want to say it in public because in case we miss the deadline, I don't want to be held to that. And then in the future, there are plans to make recontact available to expand our digital health technology footprint, all those kinds of things. So I'll close with a quote from William Harvey. I think all we know is still infinitely less than that remains unknown. And I think that's true. We're not nearly at the end of understanding everything we need to understand about biology. I'll just close by showing you a picture of the many, many people who are involved in the studies that I've shown you and other studies that I didn't have a chance to show you. I thank you again for the opportunity to give this talk, and I'm happy to take questions if there's time.
Thank you, Professor Roden. I think Arthur is still here. Arthur?
Yes, Dan, thank you for this very intriguing talk. And it's clear that it's an enormous amount of work and it paid off already, and it's going to pay off a lot. Thank you so much. So let's see whether there are questions. I have one, and that relates to the informed consent. This was in the previous talk as well. You started in 2005, and the informed consent at that time was a different one, I assume, than the one that you're asking now, in terms of, particularly in terms of dealing with the genetic data.
So
did you reconsent all the individuals for that?
No. So BioView, our resource is based on a de-identified image of the electronic health record, and part of the structure of that, after the advice of both an internal and an external ethics committee, as well as a community advisory board, is to leave it that way. So we do not return anything because we formally don't know who these people are, because we're not looking at real electronic records. We're looking at de-identified images. Now, the argument is, what happens if you stumble across somebody who has a BRCA1 mutation? And I accept that argument. On the other hand, you know, my contention is that that should be part of routine healthcare at this point, but that's another discussion. All the predict stuff and the emerge stuff that I've shown you, that always involves consented cohorts, because we have to go back to them and tell them. I will say that UK Biobank, which is, you know, I can't say enough wonderful things about the UK Biobank, but you know, that was set up with the idea of never returning anything at all to participants. So all of us is a little bit different in the sense that we're sort of set up from the beginning to try to return things, and it makes it very much more cumbersome. I will tell you that it's much easier to do the discovery science and say, this is what we discovered and let's move on. The Million Veterans Program, which is a program I'm quite familiar with, a gigantic effort. Patients are all consented for return, but they haven't figured out how to do the return properly yet. And so nobody's gotten anything back. So the consent issues are tough. When you build these very, very large resources, you have an option of consenting people for return or not. And I see the value in both of those. If I had it to do all over in 2005, I think I would have created a mechanism so that we could at least go back to some of our patients if we had to, but we don't have that luxury now. So that's where we are. And we're all I can say is we're not alone. The most frustrating part is that, as you know, we've done vast amounts of genotyping and sequencing in BioView, and we can't return any of that to subjects. And we can't return it to their electronic records for the pharmacogenetics piece, for example. We just have to do that all over again.
Okay, thanks again. I hand over to Devendra.
Okay. Sorry? Okay. Munir's hand is up.
Hello, Dan. How are you?
I'm well, and you?
Fine, thank you.
As well as can be expected.
In the current circumstances, absolutely. Just interested in what you said about all of us and the focus on underserved populations. Just wondered about, in terms of access to that resource, will it be available like the UK Biobank is to almost anybody in the world that wants to look at it, or how is it going to access be determined?
The short answer is yes. The long answer is I don't know when and I don't know how, but there's clearly an intent to make at least some of these data available in some way to the world. It would be, you know, based on the on the example of the UK Biobank. We want to make sure that the resource is available to researchers across the world. Right now, we're in an awkward position, so we have our sort of baby toe in the water. We're doing it a little bit differently. We're building it as you know, it's like building an airplane as it's flying, because We don't have our 1 million patients yet. We don't have all their electronic records in hand yet. We don't have all their biosamples in hand yet, let alone the, the sequencing that has to be done. But yet we're releasing data, on the fly, which is a little bit different from other resources, which have built the resource, to a certain size and then said, here, have at it. So we're rolling it out in tiers, and the advantage is that people get used to, the way in which this works. The disadvantage is that the data sets are incomplete and smaller at the beginning. I also should say that everything in all of us is in the cloud. So that makes data security easier. It makes compute times and computing capabilities easier as well. And I think that's the UK Biobank is going to move into the cloud. Other resources are going to have to move into the cloud. This is the first one that is actually built from the ground up in the cloud.
And will you expect researchers to be able to download the data or work in a trusted?
No, there's a word that I've learned. There is a word that I've learned that in the last couple of years, and the word is exfiltration. There will be under appropriately controlled circumstances, data can be downloaded, but that will be controlled. Mostly, we don't want data to be downloaded because the more instances there are, particularly with a data set that that is de-identified, the phenotypic data will be de-identified, but it won't be, de-identified means that you can, if you work hard enough, you could probably figure out who this person is. So we really want to make sure that we protect people's individual privacy. So there will be controls over how much data you can download and what you can use it for. The other thing is, you can't use it for whatever you like. We're not interested in having people do studies of the genomic determinants of whether you live near a food desert or whether you have alcoholism. We're just not interested in those kinds of studies, and we don't want people to do that. So we have some control over it when it's held in the cloud. So there will be conditions under which the data can be taken out. We're worried about people sneaking in and sucking it up. That's the word exfiltration.
Can I ask one last question, Devendra?
Sure.
Yeah. So
you're cutting into your own time, Manir. I mean,
if you look at the UK Biobank, it's not representative of the population of the UK. It's very, very middle class. Very lack of representation of ethnic minorities and so on. And I was interested to hear about your focus on underserved populations in all of us. So how did you manage to make sure that you had particular, a representation of underserved populations in all of us?
So the project was announced in, so first of all, let me say that I agree with you about the UK Biobank, but if you cast your mind back to 2004, 2005, 2006, when the biobank was just being designed, they did a brilliant job. I mean,
absolutely fantastic.
And the model, if they did it again today, they'd probably do it a little bit differently. But I'll just say it that way. When the program was announced in 2016, actually the State of the Union by President Obama in 2015, there was always a focus on diversity. And for the first year or two, there were pilot studies, and that many of those pilot studies involved people, actually a large group at Vanderbilt, who went around the country talking to, in church basements, talking to community groups, talking to people who we usually don't engage in this kind of process. They didn't talk to Harvard University or Northwestern University or UCLA. Man, we talk to them all the time, but they talked to sort of in church basements and places like that, community centers, and they did a real roadshow trying to figure out how to do this, what would work, and what would. So there's a lot of work that went into sort of understanding the needs of the community and how they would engage in that community, and then we started, and then along came COVID. But I think we understand the rules of engagement. And some of the centers that we've chosen, the leading center for recruitment right now is in Arizona, where they have a very, very large underrepresented population. They also have a very large Native American population, but the Native American population is engaged in all of us in a different way, which I don't think I want to have time to talk about. But that's a particular population that is, that has been not well served by modern genomics. And so they're very, very reluctant to put their toe in that water, understandably. And so there's a lot of discussion about how to do that at an appropriate level with appropriate safeguards. And so it takes a lot of work. It's not just words.
Thank you.
So I gather no more questions. I think we come to close of this conference. 3 days. We planned for 2 days, but we went on 3 days because of the Zoom and the people not able to cope more than 5 hours sitting in front of devices like the PC or whatever. But in total, we had 27 fantastic publications from very common issues to very complicated, cutting edge, modern future genomic medicine in cardiology, not only cardiology, but many other medical specialties. And I think what Professor Roden sum up implementation of genomic medicine and highlighting key examples of the cardiovascular medicine, I think that would certainly in keeping with the conference theme. Before I close, I hand over to Professor Munir Mohammed, who is the patron of the foundation. I would like to say a few words of huge thanks to my team, Nick Miles and Lisa Williams. They've been outstanding, given extremely limited resources, new technology, learning on the job, and all those things. And also members of the scientific committee from all over, and they were instrumental guiding us, selecting speakers. And we were truly international because we managed to get the speakers from Australia, India, and of course, UK, Europe, and Canada, and USA. So I think, international label on the conference could be justified. So it is a biennial activity. I'm not very sure about in 2 years' time, but certainly I will leave the door open, channel open for juniors, for youngsters to come. I'm very pleased that what we set out in 2007 with very limited knowledge and resource from 2 or 3 genes, now we are talking about the whole genome. It is a splendid movement. So thank you very much. So I will just request our patron of the foundation, because this conference is one of the highlight activity, a major activity within the Global Familial Heart Challenge, which I mentioned at the beginning of the conference. So Sir Munir, please.
Thank you, Devendra. So it's a great pleasure for me to give a vote of thanks to my friend and colleague, Professor Dan Roden, for his excellent and insightful presentation today. I'm particularly glad that you are the second person to do the VIII oration, given your focus on pharmacogenomics and the work you've undertaken in pharmacogenomics, which, as you know, is an area close to my heart. You've always been a pioneer in pharmacogenomics with a sustained output of excellent articles which have led the way and now pioneering the sort of implementation. The BioView example and how you set up BioView is a demonstrator of how you've led the way and how different groups all around the world are now replicating what you've been trying to do. It's good to see what you're doing with all of us, and you're involved with all of us. I think the way forward for all of us in terms of implementation of genomic medicine is really going to be very much about using large data sets, large resources, such as all of us, UK Biobank, and plus the other data sets which are available. And the challenge that you've highlighted about integrating multiple data sets, different sort of environmental factors, and the genetic factors together to actually identify how we develop disease, why we develop disease, and develop the best treatments and biomarkers is going to be a challenge, and we need to work across boundaries to be able to do that. And I think I'm glad that you're involved. It'd be great to be able to, link up with you on that as we move forward. So thank you very much, Dan, for presenting today. And perhaps I can ask the audience to give you a virtual round of applause. And I hope to see you in person in the near future. And also thank you very much, Devendra, and the team for this conference that you've set up. It's always very successful. So thank you very much to you and the team as well.
Thank you. I think Ajay is. Do you have a final word, Ajay? You want to say anything?
I think extremely informative. It was a fantastic conference, very informative, and a lot of food for thought for further studies. It's thank you so much for all the effort that was put into the conference.
Thank you all. I think it's a Saturday now in the UK, 5:15, and I think you all deserve rest. Thank you very much. Okay. Take care.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you, Pradeep. It went okay.
Thank you. Yeah, excellent presentations from everyone. You selected a great panel. Thank you very much for your help. And all the support team also, Lisa, Nick, everyone. Thank you so much. Take care.
Oh, thank you. Congratulations, everybody. That's a wrap.
Thank you. And have a
Certainly is a wrap. Well done, everyone. Thank you.
Excellent. Cheers.
Cheers. Bye-bye. Bye.
Bye-bye.
Okay, Nick, you can go to your local now.
Oh, thank you very much.
I don't know what's your plan, but have a nice weekend. Relax.
I will. I'll try to. I'm in work tomorrow as well.
Yeah, you're always working, but anyway, I'm sure you will go to one of your locals in Cowbridge Road, I think. Kenton somewhere.
I'll do that. I'll do that.
Lisa, where do you live, Lisa?
I live about 20 minutes outside of Cardiff in a place called Bridgend. So,
of course, we all know Bridgend, of course.
Oh, you do? For all the wrong reasons, I'm sure.
Well, you're right. I mean, there is a very unpleasant place called a designer shop,
Oh, yes, I know the one. Yeah, I'm literally just around the corner from that.
I don't like, but you can imagine my wife loves that,
Yeah, designer outlets, yeah.
Yeah, that's where I am in the world.
MacArthur designer, something?
MacArthur Glen, that's it, yes.
Well, that's
a legend that is.
Are you happy, Devendra? Are you happy with the way that everything went?
Yeah, I think minor hiccup. I mean, although I didn't realize that Mina's talk was serious recording.
Yeah.
The last minute I recall, I had difficulty downloading there, but you managed in time.
We played it well.
Well, okay. I think she joined and she apologized. So I think, I mean, everybody is a busy person. But I think we nearly missed a couple of other talks, but we managed. But I think Seema's recording was excellent.
Yeah.
She was also present in person to take questions.
Yeah.
I think we got fantastic teams. I think what we have developed over the years, and to be honest, I think people, I mean, I've learned myself and many other people have learned really on the job. We had no idea what we were talking about in 2007, in 2005, I mean. I think we have very few things. I mean, what we have discussed today is hardly 10% we could, we knew in 2007. When that program would be laughing, oh my goodness, there was a program in 2007.
Yeah, amazing.
I mean, these people, I think, at least 15, 20 years ahead of Britain, although we have got NHS, our strength. So we are clever in applying science into practice. Americans can't do that because of the cost factor.
Yeah.
I think when I practice now in India, this morning there was inauguration of a new center which I have set up there, and people can't afford. It's so poor.